mortality is nearly 45% to 70%. In other words, if 100% get infected, 70% of the humans die. Very, very highly mortal disease. But fortunately, this the RO, which I'm going to tell you later, is very low. So the communicability is very low. It needs a vector also. So fortunately, mankind has not fallen trapped to this illness. Usually, the human beings get the disease through animal exposure, through piggery, or when they go for trekking or hunting, when they take unwashed fruits, or drinking raw sap or the toddy, or getting exposed to suspected cases of Nipah. So these are the ways in which human gets a disease. So if you look here, from the natural hosts, fruit bats, it can either directly to man by consuming fruits or through pigs. From there, man-to-man transmission happens, which happened a couple of years back in Kerala. So basically, the symptoms are very vague. You get a sudden onset of high-grade fever with headache, some of them going for mental confusion, drowsiness, disorientation. Very rarely, they go into coma and sudden death. So if you look at the pathophysiology, the virus enters through the nasal epithelium. From the nasal epithelium, it goes antegrade through the olfactory nerve to the brain. So to suspect a Nipah, fever is 100% present in all cases. So when somebody gets a sudden onset of high-grade fever with intense headache, severe myalgia, with or without dizziness and drowsiness, you have to keep suspicion of Nipah in the back of the mind. Not in all cases. Wherever who had gone to orchard or gone for trekking or gone for mountaineering or had a contact with a suspected case or recently having traveled to Malappuram or Kozhikode, the areas where Nipah is endemic. So you have to be very, very careful because suddenly from this state, they can go into sudden altered sensorium, encephalitis, coma and death. So you have to suspect early, particularly in the districts where, Tamil Nadu districts where we are bordering Kerala. So many a times in the past, we were thinking it was Japanese bee encephalitis. We didn't do identification of Nipah. Now, many a times, this Nipah has been closely related to those who are suspected JE. The actual virus was Nipah. So if you look at the Indian experience regarding the lab parameters, many of the cases in the Northeast and also in Kerala had a normal CBC. Leukopenia was present only in 11% of the cases. You know, many of the viral illnesses, leukopenia is a prominent finding, whereas in Nipah, it's not that prominent, particularly in the Indian setting. And thrombocytopenia was around 30%. Many of them had elevated liver enzymes. Though this virus is a neurotropic and pulmotropic, it affects the brain and the lungs. It has a predilection for liver also. If they got respiratory symptoms, if you take an X-ray, you will have an ARDS-like picture. And though the confirmation is by blood or CSF by RT-PCR or Nipah antibodies, I'll tell you about this confirmation test later in my slide. So here, whenever you have a suspected case of Nipah, please do these 4 things. One is you need to take at least one of the 4 samples. And it has to be done within 4 days of suspicion of Nipah. And it has to be sent by biosafety precaution. And when you are taking also, you have to wear full covered dress like as we did for COVID. PPE is very, very important. And when you are sending the sample, it has to be sent to NIV Pune with a detailed history in a prescribed format. That's very, very important. History and the format is very, very important when you are sending sample to NIV Pune, National Institute of Virology. The 4 samples are throat swab that is taken from the posterior wall, transported through viral transport media, number 1. And the other 3 samples are urine, blood, and CSF. They are all sent in sterile containers. Urine in 10 ml, CSF 1 ml, and blood 5 ml. These things has to be sent to NIV Pune with a prescribed format with a detailed history. This is the thing what you need to do. Suppose if you are in a government medical college or in a private practitioner whom you suspect Nipah, you have to follow these guidelines. And the mainstay of Nipah management is supportive. As I told you, vast majority are asymptomatic, subclinical. They do not require any treatment. ILI-like feature symptoms, you need to keep them, isolate them, and then if they are not sick, you can manage them at home, only supportive therapy. If the patient has got poor prognostic signs, you have to be very, very cautious. The most important of them is altered mental status, unconscious level, and a respiratory distress. You need to admit them, you need to isolate them, you need to inform the health authorities, you need to take samples, the 4 samples I told you, and then start the patient on ribavirin. Ribavirin reduces the hospital stay and also reduces the need for ventilation and also ventilation duration. New drug called monoclonal antibody M102.4 has been found out to be very useful. Though there were many drugs that were tried for COVID were also tried for Nipah, but they were did not have a very good evidence. So coming to the last few slides. So if you look at the R0 of any disease, if it is more than 1, that disease has got potential for causing pandemics and epidemics. Fortunately, Nipah R0 is only 0.4. So epidemics are less likely, but the knowledge for suspecting Nipah and managing Nipah has to be in epidemic promotion inside the Tamil Nadu, because we are bordering Kerala. So anytime we can get it. So at this juncture, I like to appreciate the government of Tamil Nadu for taking rapid steps in educating all the doctors. And public education is very, very important, because it is the public education that is going to reduce the severity of the disease, particularly what we did during COVID. In fact, IMA and IAP started educating the public and also doctors even before the corona outbreak. I was one of the few doctors throughout the country doing corona education even before the COVID started appearing in India. So in hospital, as I told you, you have to isolate, you have to intimate the health authorities. That's 2 very, very important I's. And as I told you, at present, we don't have any vaccine. There is a promising mRNA vaccine that is in the pipeline. And also another vaccine that's used in Australia for in the veterinary, in the piggeries. So these 2 vaccines are promising. Probably in years to come, you'll be getting these vaccines. So let me go to the next important topic, that's on dengue. Please remember, dengue is not a platelet disease. Let me start with this very, very important point. I'm going to talk about a disease which is not a platelet disease. My approach during this seminar is going to be D approach. That's 3 Ds. One is do's, another is don'ts, that is third is definite. If you follow this 3D approach for dengue, you will be successful in managing the dengue, and your mortality out of this dengue, particularly in your clinic or your hospital, is going to be 0. Collectively, entire Tamil Nadu, if you are able to do this do's and don'ts and definite treatment, you can reduce the mortality of dengue in Tamil Nadu to 0. So these are based on Government of India guidelines, National Vector-Borne Disease Control Program, and WHO guidelines. Friends, once again, I like to bring warm greetings from Coimbatore Child Trust Children's Hospital. This is going to be evidence-based approach, and this slide is very, very important. I request all of you to take a picture and keep a color printout and keep it on your table. This slide will tell you about the illness, management, when to do, when not to do, when to admit, when to discharge, everything in a single slide. Basically, dengue is a 11-day illness. If you get a fever of beyond 11 days, think of beyond dengue. In dengue, in HLH, you can have a disease beyond 11 days. Generally, dengue is not a 11-day disease. Beyond 11 days, it's fever is probably non-dengue. If you look at the first 3 days, it's a febrile part. During the febrile part, child be having a high-grade fever. Probably child has a headache, muscle pain, body pain. It's called breakbone fever. And classically, the headache is retroorbital headache. If the child can verbalize, child will tell, "Kannuk pinnadi valikudung doctor." So during the febrile period, please remember, the only thing you need to do is to give paracetamol. The two, if it is a younger child, try to give paracetamol at the dose of 10 milligram per kg per dose, not to exceed 80 milligram per kg per day, because dengue is a hepatotropic virus. Many of the admissions in our hospital during the dengue epidemics were due to paracetamol poisoning rather than due to dengue. So please give a reduced dose of paracetamol. Do not worry about the height of fever. Educate them about the hydration, because hydration is the most important thing. In a younger child, you need to give WHO reduced ORS, which contains sodium of 75 milliequivalents. In older child, you can give WHO ORS. The dose of ORS is 50 ml per hour in younger children, and older children it's 100 ml per hour. So only two drugs. One is paracetamol, lower dose. Second is ORS. Never give NSAIDs, because many a times when you give NSAIDs, fever will come down. The child will have thrombocythemia. Child will have a major bleeding in spite of having a normal platelet count. So do not give NSAIDs to reduce fever, particularly in dengue. During a dengue outbreak, do not use mefenamic acid, because mefenamic acid can cause thrombocythemia, and also in children less than 5 years, it can induce seizures by itself. Mefenamic acid is a seizurogenic drug. So I request all the doctors in Tamil Nadu, particularly when you have a child with viral fever, please use paracetamol. Do not use any other drug other than paracetamol. Do not give IM injection paracetamol to satisfy the parents, because the child is in the prodromal phase of viral illness like polio. Your injection can cause a provocative polio. Your whole practice will be lost. Never satisfy the patients by giving IM injection. Never use steroids. Febrile period, only paracetamol and ORS. Very, very important. The only complication is dehydration. Make sure the child passes urine every 6 hours, at least 4 to 6 times a day. That's the only thing you need to tell. Another important thing is, do not do CBC on day 1, because most of the time CBC will be normal, but the child will be abnormal. And the changes in the CBC happens by around 3rd day during the disappearance of fever. If at all you want to do, a child is having high-grade fever, if at all you want to do a single test on day 1 of fever, it should be urine microscopy. It's not CBC. And please remember, viremia takes first 3 days to disappear. At the time of disappearance of viremia, the NS1, which appears within hours of viremia, within hours of starting fever, disappears by around 3rd day when IgM started appearing. The IgM neutralizes the viruses and NS1 disappears. NS1 is nothing but non-structural glycoprotein that is seen during the viremia. So if you do NS1, many of the dengue illnesses, children with dengue virus, NS1 will be positive. Another important message is, during the febrile period, if you suspect dengue, we do NS1. Just do not admit the child just because NS1 is positive, because nearly around 70% of the dengue are subclinical. They have only fever. Otherwise, child does not develop any danger signs. Only minority develop danger signs. NS1 is present positive means dengue virus is there in the child's body. It doesn't mean child has got a disease. So do not admit the child unless the child has got danger signs. Just because fever is there, child is active, child taking food, urine output is good, no danger signs. Do not admit just because NS1 is positive. And also NS1 you have to do by ELISA method. Do not do by CAR test, because you got lots of false positivity when you do by CAR test. So that's about febrile period. Febrile period, very simple. Treat like any other virus. Give lower dose of paracetamol, give in no other drug other than ORS. Now coming to the next 3 days, 3rd day to 6th day, this is the very, very crucial part of the dengue management. If you miss the boat, you land up in failure. So 3rd day to 6th day, particularly the time when fever disappears. If you look at the fever graph, there is a camel hump pattern, biphasic fever. பின்னாடி முதுகுல ஒட்டக செமிக்கெல்லாம் முதுகுல 2 திமில் இருக்கும். ஒரு திமில்ல பின்னாடி ஒரு திமில். அது மாதிரி இட்ஸ் அ கேமல் ஹம்ப் ஒட்டகத்துக்கு. அது மாதிரி வந்து ஃபீவர் இல்லாதப்ப தான் காம்ப்ளிகேஷன் வரும். So during febrile period, every child that walks into your chamber, whether you got a simple 10 by 10 consultation room, you have to educate them. Education is the most important thing. Tell them about warning signs. I'll tell you what are the warning signs in the next slide. You educate them and send them home. Tell them even if there is no fever, they have to come back if there is a warning sign. Please remember, in dengue, The complications start 24 to 48 hours after the disappearance of fever. And abdominal pain is the most important sign that prompts you to admit the child and start on treatment. In any child who had a high-grade fever, fever disappeared, child gets an abdominal pain, please keep dengue in the back of the mind. Make the child lie down, put your hand on the right hypochondrium, feel for liver. If there is a tender hepatomegaly, do not send them back. Do not give them ranitidine. Do not give them antacids. This is nothing but child slipping into second stage of dengue, or called critical stage of dengue, or a leaky phase of dengue. This child needs hospitalization. So during this time, these children go in for shock, they go in for bleeding manifestation, they go in for organ impairment, particularly liver and the kidney. So tissue hypoxemia is very, very important complication. Many of the children go in for shock. Another important thing which we need to know about dengue shock is that these children can walk with shock. They'll come to you walking with shock. So whereas in septic shock, the child be lifted up and brought to hospital. Whereas in a dengue shock, they'll be walking with shock. That's another important thing. And if you look at the SpO2 will be normal. If you look at the systolic pressure will be normal. Only the diastolic will go up and the pulse pressure will become narrow. So you have to be very, very careful. The child be smiling at you in a severe shock. So CNS involvement will not be there in dengue shock. So they'll be saying good morning, but the child be in shock. That's very, very important. Coming to the lab parameters in shock, the most important thing is whenever you look at the CBC, first thing you need to see is hematocrit. Never look at the platelet. Hematocrit, suddenly it will start rising. So hematocrit rises means there is a efflux of fluid from the intravascular compartment to the extracellular compartment. There is a hemoconcentration inside the intravascular compartment. So that means there is a leak that's going on because of the antigen antibody induced vasculitis, capillary leak. There'll be intravascular degradation. Hematocrit suddenly starts increasing. If you have a hemoglobin of 12, the hematocrit usually is 36, 3 times into 3. So if there is a hematocrit that is beyond 40 or 42, there is a hemoconcentration. So child who is afebrile after 3 days of fever, please admit the child. Whenever the hematocrit goes up, we just keep the child inside. Particularly, this is one among the warning signs. And the other warning signs I'll tell you later. Coming to the thrombocytopenia, please remember right from the beginning, I'm telling you, dengue is not a platelet disease. This thrombocytopenia is because of a pattern called molecular mimicry. By around third day, our body starts producing IgM. For the postgraduates, IgM starts appearing in the body by around third day. It will disappear by around 3 months. IgG starts appearing by our 7th day. It will disappear by 70 years, lifelong. So that's a mnemonic. 3 days, 3 months, 7 days, 70 years. This thrombocytopenia is because of molecular mimicry. The IgM antibodies that are produced in our body are supposed to destroy dengue virus. Since the platelets have got same molecular pattern as that of dengue virus, instead of destroying the virus, it destroys our own platelets. So more thrombocytopenia means more IgM antibodies. It does not have any clinical correlates. Please remember, you can have very sick children with bleeding with a normal platelet count, and you can have normal children with a low platelet count. So platelet count is not an indication for starting platelet transfusion, or thrombocytopenia is not an indication for referral. If the child does not have danger signs, you can manage thrombocytopenia as a simple dengue protocol. You need not give platelet transfusion. And your referral has to be based on the danger signs. Even if the platelet count is normal, if the child has got danger signs, please refer them early. Because by referring early, you can reduce dengue mortality in Tamil Nadu to 0. So that's what we aim. Our long-term aim is to do that. And our Ministry of Health, Tamil Nadu is doing a wonderful work, and also IMA Tamil Nadu, IAP Tamil Nadu are joining hands with them to educate all the doctors and public, so that in near future, we'll be the first state in the country to achieve a 0 mortality in dengue. So having seen this, whenever you look at the CBC, please look at the hematocrit, not the platelet count. And many times you find in dengue, you have leukopenia, the total count becomes low. This low platelet count, low WBC count is because of this simple fact. These viruses, dengue virus, enter into WBC. When one single virus enters into WBC, it multiplies to lakhs and kills the WBC, makes a puzzle and ruptures, comes out. These 1 lakh viruses enter into more WBCs. So the viremia is enhanced by the presence of WBC, helps to enhance the viremia. So what the body does is, body down regulates the production of WBC. So there is a leukopenia, so less viremia, so less the disease. That's a protective mechanism by the body. That's why you get a leukopenia. So having seen this very, very important slide, please take a picture of this, or at the end of the meeting, you can send a WhatsApp message to me. I'll send you the slides. So I'm going to, as I told you, 3 Ds. First 2 Ds are do diagnose viral fever by applying your knowledge. Do not misuse antibiotics. And another important you need to do is you need to educate them about danger signs and keep a watchful eye, particularly after the disappearance of effervescence of fever. Don't do CBC on day 1. Prescribe only antibiotics, only paracetamol. And definitely, you must know that this is an evolving illness. The complications can arise in few of the children with viral fever. They have got a dengue-like illness. That unnecessarily do not give antibiotics. These 2 are definites. So let's look at these WHO recommendations. Children with or without warning signs can become severe dengue with plasma leak, hemorrhage, and organ impairment in matter of hours. So dengue needs a close observation, particularly when you keep them inside the hospital. So these are the center 6 or the danger signs. Danger signs can be classified according to the organ systems. I'm going to tell you about the 5 important danger signs. Please write down in Tamil and ask every patient who comes with a cell phone to take a picture. And you have to write this in 7 places: on your consultation room, behind the door, in the medical shop, in the lab, everywhere where they go, they have to look at these danger signs. If you educate them about these danger signs, you can reduce the mortality of dengue to 0. One is CNS. In CNS, younger child excessive irritability or older child excessive drowsiness. அதிக 9 அழுதிட்டு இருக்கிறதோ இல்ல சோர்ந்து படுத்து தூங்கிட்டே இருக்கிறதோ is a danger sign. Second is cardiovascular. கைகாலெல்லாம் ஜில்லுன்னு இருக்கிறது. Ask the parent to keep one hand on the chest, another hand on the feet, and see difference between 2 temperature. If the chest is very hot, abdomen is very hot, and the feet are very cold, that means the child is going for shock. CRT will be prolonged. You have to lift the limb above the heart level and press it with your thumb for a few seconds and see the capillary refill time. If the capillary refill time is prolonged, this child needs hospitalization, cardiovascular. And the third is abdominal. If the child has got severe abdominal pain, particularly involvement of the entrapment of the liver inside a TENS capsule, by the time of disappearance of fever is an important warning sign. Nausea, vomiting is another important vomiting sign, warning signs. Abdomen. And the fourth is renal urine output. The normal GFR is at 1 ml per kg per hour. That is, a 10 kilo child should pass 60 ml every 6 hours. If the urine output is less than 0.5 ml per kg per hour, in fact, if it is less than 1 ml per kg per hour, the child hasn't voided urine for more than 6 hours or 8 hours. It's a candidate to be admitted. So renal. And the last is hematological. In hematological, you got clinical. In clinical, if there is a minor bleed or a major bleed, you need to admit them. Or if the child has got sudden increase in the hematocrit, you need to keep the child inside the hospital. These 5 important danger signs has to be educated to the parents, and then tell them, even in the absence of fever, if these danger signs are there, even one is there, please come back round the clock, 24 hours. Or if you have a clinic, tell them that go to government hospital nearby or a PSC or a GH, so that the parents' education about the danger signs very, very important. Because having gone throughout the globe, I myself through WHO, I've gone throughout the globe. Smaller countries like Malaysia, Thailand, Indonesia, Vietnam, They have reduced the mortality to nearly zero just by public education. So this education is very, very important. I once again stress every practitioner who is attending this meeting to write down in Tamil and educate all the parents about these danger signs. Whatever, not only in this viral fever, any viral fever, if there are danger signs, that means child is losing the war. They have to come back for admission. This public education will reduce the mortality to zero. So the important message is educate every patient about warning signs and always write in Tamil and ask them to come back if there is danger signs even in the absence of fever. Never give IM injections and do not give IV fluids as an outpatient. If you have a clinic, and do not give morning IV fluid, evening IV fluid, because dengue is a continuous disease. There will be leak 24 hours from the intravascular compartment to the extravascular compartment. Because when we did postmortem analysis, we found out those children who received BDIV fluids increase the mortality rate. So always admit them, give 24 hours IV fluids. And definitely you need to monitor them clinically and hematologically, because then child with simple dengue can become severe dengue in a matter of hours. So I request all of you to do a simple test called HES test or a tourniquet test. During the question and answer session, I'll tell you how to do tourniquet test. And please remember, when you do NS1, do by ELISA method. And remember that NS1 means there is dengue virus inside the body. Do not admit the child just because NS1 is positive. The child is a well child. Only when there is danger sign, you can admit. Otherwise, you educate them, come back if there is a danger sign. And then from today, focus on platelets. Do not focus on platelets, focus on the patient. Dengue is not a platelet disease. You can have a severe dengue with a normal platelet count. You can have a normal child with a low platelet count. And always gold standard is to do IgM, IgG by ELISA method after 5th day. So suppose if you have a child who has a suspected dengue, do not wait for the reports. Based on a clinical judgment, you can write it as dengue-like illness, start the treatment. What the WHO says is, even before wait to get the report whether it is dengue or not, start the treatment. Because many a time there are some viruses that behaves like dengue, but the serology will be negative. But the WHO mentions that the management as per WHO protocol is mandatory. If you think the child has got danger signs, keep the child inside and start IV fluids. And during the febrile period, I already told you about very, very important points. Most important don't is do not encourage commercial fluid. Many mothers come and tell you, my child will drink Fanta or Limca or Coca-Cola. My child will not drink tender coconut water or ORS. Do not encourage commercial drinks because they contain more than 10% of glucose that will cause cerebral edema. So do not encourage commercial drinks. And never yield to parental pressure, because many at the time they will request you to give IM injection or any other drug to reduce fever. Please remember, fever is not a disease per se. It is the underlying disease that causes mortality, not the fever. So do not chase the fever. Make an evidence-based diagnosis and educate them. That's the most important thing. And this algorithm is very, very important. I request everyone to take a picture of this. Whenever you suspect a child with dengue with warning signs, first thing you need to do is, when you put an IV line, take CBC, look at the hematocrit, start on normal saline. Normal saline is a fluid that has to be started. Always normal saline, normal saline, normal saline. The dose is 7 to 10 ml per kg. It has to be given slowly over 1 hour. Do not give a push until the child is in severe shock. Normally, with danger signs, give it over 1 hour. Then at the end of 1 hour, repeat a CBC. Look for hematocrit. If the hematocrit started decreasing from 42, it has become 40. That means you are on the right track. Look for the vital signs, particularly look at the pulse volume, look at the urine output, look at the heart rate, look at the respiratory rate, look at the pulse pressure, difference between systolic and diastolic. If there is no improvement in hematocrit or other clinical parameters, the child remains cold and clammy, not past urine. you are advised to give second bolus of 10 ml per kg weight of normal saline over another 1 hour. After second bolus, if there is no improvement, that is a child whom you have to refer to higher center where there is PACU. Do not keep them in a small hospital where you don't have facility to go for further investigation and management. So after second bolus, the child continues to have hypotension or a shock, you need to refer to higher center. In centers like us where we have PACU, we see whether there is a sudden drop in hematocrit after second bolus. If there is a more than 10 to 20% drop, this child has got occult bleeding. We give freshly transfused packed RBC at 10 ml per kg even without a clinical bleed, because that can prevent a major bleed. If there is a sudden increase in hematocrit, that means child is going for very severe leak. We give colloid, preferably FFB at 10 ml per kg. So if there is no improvement after 2 boluses, do not keep them in your hospital. And there is an improvement on the other arm. You can, if the pulse is stable, CRT is becoming normal, peripheries are becoming warm, there is a good urine output, hematocrit is dropping down. Every 3 hours, you can gradually reduce from 10 ml to 7 ml per hour over 2 hours, then reduce to 5 ml per hour over next 2 hours, then gradually reduce to 3 ml per hour. From 10 ml, do not come to 1 ml. Gradually, you have to reduce. And then try to encourage oral feeds as early as possible. The child is able to accept oral fluids, change it to oral fluids as early, because continuing IV fluids beyond the critical phase, during the recovery phase, you will land up in pulmonary edema. That's called hydrogenic pulmonary edema. If you give IV fluids during the febrile phase without danger signs, you will land up in compartment syndrome. So IV fluids has got very, very narrow therapeutic index. It has to be given only for 48 to 72 hours. The do's and don'ts are: do monitor hematocrit, do monitor IO chart, try to maintain above 1 ml per kg per hour. Do not rely upon systolic BP. As I told you many times, it will be normal. The diastolic will be rise and the pulse pressure will be narrow. SpO2 in many of the children, even with shock in dengue, will be near normal. So always do not rely upon sensorium, because even in our hospital now we have a child, a 3-year-old child going for pre-KG, now having severe dengue shock, but this morning said, "Good morning, doctor." So sensorium will be nearly preserved in dengue shock, and they can walk with shock. The only fluid you need to start is normal saline, normal saline, normal saline. Do not start on dextrose containing fluid, because you will land up in neuroendocrine stress phenomenon. And never give prophylactic platelets. And also another important point, do not give drugs to improve platelet count. Dengue is not a platelet disease. Forget platelet, focus patients. So last carry home message, as I told you, do not give BD IV fluids. Monitor inpatient carefully. Dengue shifts from simple dengue to severe dengue in a matter of hours. Forget platelets, focus patients. Reference should not be based on the clinical condition and not based on the platelet count. So it is the disease that causes fever that kills a child. Do not chase the fever. And I request all the doctors to do a triage for every fever patients. It takes less than 30 seconds. Please do CCTVR. Look at the pulse volume, capillary refill time, color of the child, temperature of the extremities. If you are able to do this, even an uneducated person who is in your clinic as a receptionist, they can do this CCTVR. If they can do this, if you can identify a sick child, bring the child inside, even in a busy OP. The outcome is time and knowledge sensitive. So if you are able to pick up and identify, admit the child, start treatment immediately, you can reduce mortality to 0. So your knowledge is going to save your patients. So with that, once again, I like to thank you all for the patient hearing. My appreciation to IMA Tamil Nadu and also CGP Tamil Nadu for taking this initiative. Those who want the slides, please note down my number. My number is 98422 11179. You can send a personal request to me. I'll send you the slides. 98422 111 11179. So I'm going for a physical meeting now. So if there are any questions, you can ask me. You can unmute and ask me. Or you can put it in the chat box. Dr. Mohan Kumar, who is the coordinator of the show, who is one of the organizing members of the infection disease certificate course. Friends, we have got a IMA CGP infection disease certificate course, a 6 months course with Tamil Nadu Medical Council credit hours of 10 hours. The first course, 3 courses are over. Third course is running. If you are interested, you can join the next course. So keep yourself aware. You can contact the CGP office in Chennai, or you can contact CGP president and secretaries. You can join the course, the 4th course. So on behalf of our infectious disease certificate course, Dr. Former DPH Director of Public Health, Dr. Kulendeswamy, Dr. Raghunandan, Dr. Mohan Kumar, infectious disease consultant epidemiologist, CDC, and Dr. Suri Kumar, microbiology head of the department, Medical College Dindigul. I wish you all a happy learning and thank you for giving this opportunity. At present, we don't have any vaccine for dengue. We are doing a phase 3 trial. Probably in years to come, we'll be getting a very, very good vaccine. Already we got a vaccine for malaria. Soon we'll be getting a vaccine for dengue also. Unfortunately, we had Sandil. Okay. 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 Yeah. Okay. கண்டுபிடிச்சிட்டேன் மேக் ஹோஸ்ட் எஸ் பண்ணிட்டேங்க யா ரகுந்தன் சார் ஆல்ரெடி இருக்காரு சரி சுரேஷ் இருந்தா சுரேஷ் பண்ணிருங்க நீங்க ஆயிட்டீங்களா ஹோஸ்ட் ஆயிட்டீங்களா அவரேதான் யா யா தேங்க்யூ So if there are any questions in the chat box, NS1 CART test is positive. I told you NS1 by CART test is a less reliable test because 33% false negativity and 33% false positivity. Even in other dengue-like viruses be positive. So it's not a reliable test by CART test. So do not do CART test. That's a recommendation by the government of India and also by WHO. Never rely upon CART test. It's either clinical or after end of 5th day, you go by NS1, IgM, IgG by ELISA. Or if you want to do it earlier, you do it by ELISA method, not by CART test. CART test is not advised by the government of India. Dextrose should not be used in dengue because, as I told you, already there is a leak from the intravascular compartment to the extravascular compartment. There will be dehydration, and you have to give isotonic fluid, which is normal saline, to get back the fluids, increase the intravascular compartment. If you use dextrose containing fluid, you will land up in neuroendocrine stress phenomenon. You will have a cerebral edema, seizures. You will develop invite complications rather than getting cured. Never use dextrose. Dengue reinfection can be possible. There are 4 types of dengue. Dengue type 1, 2, 3, 4. Because if you get type 1 for the first time, second time you can get it type 2. Because the antibodies against type 1 will not give cross protection against type 2. Unfortunately, these antibodies are called disease enhancing antibodies. Sometimes when they get type 1, when they get type 2 for the second time, the disease will be severity will be nearly 200 folds high. That's why in secondary dengue, the complications are more. So if you are getting for the second time, the complication is more. In our experience, if you can get the dengue third time or the fourth time, the complications are less. Tertiary dengue, quaternary dengue, complications are less. So secondary dengue, you have to be very, very cautious. How can you identify the child is sick, having danger signs? Whether it is primary or dengue, do not worry. Admit the child, treat as per WHO protocol. Short on normal saline. That's an important thing. After fifth day, if you do IgG and IgM, when IgG is strongly positive, with IgM positive or negative, probably you are dealing with secondary dengue. So when IgG is strongly positive, you are dealing with secondary dengue. You have to be very, very careful. So as per WHO guidelines, there is no role for any drugs to improve platelet count or any role for other kashayams and other things, because this is going to be evidence-based protocol as per WHO. They do not have any role in the management of dengue. Sometimes we do see lots of children having two diseases in given child. Sometimes we do see dengue with typhoid, dengue with typhus, dengue with malaria, dengue with lepto, dengue with three diseases. Last time we had one child from Arunachal Pradesh who happened to travel to Tamil Nadu to work in a mill. His son had dengue. He had dengue, malaria, and also he had typhoid. So culture positive typhoid, IgM, IgG by ELISA, dengue strongly positive, and also he has had PS peripheral smear study positive for malaria. So in that case, you have to treat all the three at the given time. Mortality is very high when there is a comorbid illness. If the fever is beyond 11 days, if the child has got hepatosplenomegaly, in dengue usually you get only hepatomegaly. If you got hepatosplenomegaly, and if there is a leukocytosis, if there is lymphadenopathy, all these things are in favor of two diseases or thing beyond dengue. So now I request, thank you for giving me this opportunity. I request the next speaker, Dr. Raghunandan, to talk about scrub typhus and typhoid. And I also, after him, I request Dr. Suresh Kumar to talk about flu and leptospirosis. Thank you for giving me this opportunity. Sorry, I could not. Thank you very much. Raghunandan sir, you can start sharing your slides, sir. Sendil, you can make Raghunandan sir as co-host. Hema Raghun irpanga. Have I left any questions? You can give paracetamol once in 6 hours. You cannot give paracetamol once in 4 hours. If there is a fever in between, you have to monitor them, and then you have to wait and give paracetamol only once in 6 hours. Raghunandan sir, you can start sharing your slides. Secondary dengue is a time when you get dengue for the second time. So when you get dengue for the second time, it's secondary dengue. Many times, first time dengue, parent would not notice, because if you look at the history of dengue, many children, they will have dengue, but they will go to the hospital for minor skin rash or a headache or a cough or a cold or a diarrhea. That's called undifferentiated dengue. Neither the doctor nor the patient know that the patient has got dengue. So many a time, primary dengue goes unnoticed, and they will be coming to you as dengue, but that will be a secondary dengue. You have to keep that in the back of the mind. Capillary refill time is lift the hand above the heart level or lift the feet above the heart level. Press it for a few seconds and then release it. And then the capillary that is blanched has to become pink within a matter of 3 seconds. That's normal. If it is beyond 3 seconds, say 7 seconds or 8 seconds, 10 seconds, the child has got prolonged capillary refill time. The child is going for shock. You need to admit them. So that's very, very important. Raghunandan sir, you can share your slides. There is no role for doxycycline in dengue. Please remember, do not give doxycycline, misuse the antibiotic. It is given for scrub typhus. Sometimes if you know the patient has got scrub typhus and dengue, you can use that doxycycline. Otherwise, do not give. Sometimes, as per theoretically, this doxycycline has got a effect, particularly in neutralizing IL-6, tumor necrosing factors. If the child patient is going for cytokine storm, you can use doxycycline, but there is no definite role for that. It's a theoretical. But definitely, when you think two infections like scrub and dengue, you can use doxycycline. The dose of doxycycline is 4 to 5 milligram per kg once a day. Tourniquet test is apply a tourniquet about 1/3 of the size of the arm. That is, it should be 1/3, covering 1/3 of the length of the arm, and then apply it firmly. And first raise the BP to systolic, and then gradually reduce it. You have to see 1 square inch below the volar surface of the forearm. Gradually reduce from systolic just above the diastolic, and keep it for 2 minutes, and then gradually release, and slowly reduce it. Then after 1 minute, you see the 1 square inch. It's not 1 square centimeter. If there are more than 10 pk, then its tourniquet test is positive. And the sensitivity specificity is very good, more than 95%. If it is done above the beyond the second day of fever. That is, whenever there is a capillary fragility, whenever there is a leak, you can have this tourniquet test positive. During dengue monsoon, when tourniquet test is positive, invariably you can say it is a clinical dengue. Raghunandan sir, you can share your slides, sir. Please go ahead.
Is it visible, sir?
Yes, sir. Your slides are visible, sir. You are audible, sir.
Okay. Thank you, sir. So can I start the presentation?
Yes, sir.
Okay. Good morning, all. First of all, I thank all the office bearers of the state branch of Tamil Nadu of IMA, and also the national branch for arranging this relevant or important CME program. As Dr. Neminathan has rightly said, now the monsoon has started, and in the next 2-3 months, we are going to face acute febrile illness as one of the common clinical problems that we are going to manage in our practice. So all the 6 topics are very, very relevant on today's context. So Dr. Neminathan has already started the ball rolling with the 2 important problem of Nipah. Even though in our state it's not a major issue, but we have to be very, very vigilant, especially across the districts in liaison with the Kerala. And of course, dengue is a very, very important critical topic for understanding. So I'll be very happy to take up some more questions on dengue also, since Sad is leaving for another meeting. As far as adult management is concerned, if the participants have any questions, we can discuss in the end of this my talk. So my talk today is going to be on 2 important topics. One on the scrub typhus and other on the age-old typhoid fever. In fact, I would like to call it as an enteric fever for a simple reason, which I will tell you later. So when you are handling a fever or an infectious disease, It could be a organ-based infections, or for example, respiratory tract infection or a urinary tract infection or a gastrointestinal infection. It could be a organ-based infections, or we call it as a acute undifferentiated febrile illness, like AUFI, acute undifferentiated febrile illness, under which they classify into malaria and non-malarial components. So therefore, all the diseases today we are going to discuss on the non-malarial acute undifferentiated febrile illness, of which now first we'll go to scrub typhus. So my talk includes very interesting etiological aspects and epidemiological aspects. And for any diseases to be managed effectively, we should understand the natural history of the disease, including its pathogenesis, of course, the clinical manifestations and laboratory, and how to confirm our clinical suspicion based on clinical as well as on laboratory, and other close differential diagnosis, and finally on treatment and prevention. In fact, all the diseases, for example, dengue, your scrub typhus, leptospirosis, malaria, and typhoid, they are all overlapping syndromes. I would say it's an overlapping syndrome. That is where the clinical examination every day and proper history is going to be a very important factor in our clinical diagnosis. Coming back to our topic of today is on the scrub. It's a rickettsial. These are the very, very small. When we are reading microbiology, we never showed so much interest on these diseases, but of late, it has, especially in our Tamil Nadu, districts like Chennai, Vellore, Krishnagiri, Dharmaburi, Coimbatore. These are the few, especially Krishnagiri and Dharmaburi, they have got the maximum prevalence of this scrub typhus. And in today's world of traveling so fast, it doesn't matter whether he is from particular district, because the travel has become a very common phenomenon. So coming back to our thing, it is also known as Chigar-borne typhus. It is transmitted by a mite. So it's a vector-borne. It's a vector-borne diseases. It is transmitted by a small mite, which we call it as chiggers. So humans, they get infected when they are bitten by these chiggers. The mites or the chiggers, they feed on the serum of warm-blooded animals only, once only in their life, in the larval stage. The adults feed on the plant juices. In fact, this disease dates back to 1944, when US Army, where people were more affected and they have lost half of their urine. Since then, it has been a very interesting disease, and even the soldiers used to call it as a Shishisto fever or Atsuga fever. So at last, it was identified. The bug was identified in Japanese in 1930 by Sutsukamushi. That's why it is also, the parasite is named under him. It is an intracellular gram-positive. The disease is called scrub. Why it is called a scrub typhus? Because it generally occurs after exposure to areas with scrub vegetations, because this is where these rodents predominantly live. It can be also prevalent in areas like sandy beaches, mountain deserts, and forest. So it is, as I said, it is commonly found in our Southeast Asian countries, especially in India and southern India. So this is called as an interesting triangle, north, south, and west triangle. And these are the areas of areas where scrub typhus were found to be on high prevalence. Again, in India, as I said, it is prevalent for quite some time. And especially in Tamil Nadu, I already mentioned the districts where it is already highly prevalent. The mortality ranges from 1 to 60% depending on the early diagnosis. It's a very interesting disease where it can involve multi-system involvement. So when we go to the clinical features, we'll try to highlight more on that. And all races and both men and affected, again, all age groups are equally affected. So this particular slide tells you the vector and the causative agent. Even though it looks like a bed bug, something like that, but in practically it is not visible to our eyes. So if you look into this life cycle, this is where this larva, they try to have a blood from the rodents, but incidentally, man becomes a accidental host. That is how the people who are exposed to these kind of soily regions or scrubs areas, this larva might bite the humans and humans become the accidental host. Because why this is clinically important is the characteristic clinical feature, what we said as a eschar, is the point on which this larva enters the human body. So this is the life cycle. And again, as I said, man is the accidental host. Otherwise, normally they bite the rodents. So again, all the seasons are mentioned, but today with changing climate, no month is exempted for any particular disease. Yes. Coming back to our most important component of this talk is eschar. What is this eschar? This is, as I already told, it is a point where it enters the bug enters the human body. Again, what are the risk factors? I already explained to you. It's usually occupational, or it could be agricultural exposure like oil palm, rubber plantation, rice fields, and also during travel activities such as rafting and camping also it can occur. Again, military, we already saw in the US thing, it has affects the military personnel. Again, it can be it can be vertical transmissions. It can occur in the form of from mother to neonate can also is possible. Again, this particular slide is important to understand the pathogenesis of this particular infection. So if you follow this flow chart, inoculation, as I said, the place where this bug bites something, it becomes eschar. Then they go into the regional lymph node enlargement. So one of the clinical features that we clinically look for is the enlarged lymph nodes. Again, it gets into a spread by bloodstream. So we could involve multi-system, which we are going to learn later. And it can invade the vascular endothelium and it can cause general organ hyperemia, and generalized lymphadenopathy also. So, as Dr. Neminathan sir was repeatedly telling about the duration of illness of dengue, usually it is around 10 to 12 days. But when it comes to scrub typhus or the next disease which you are going to learn on enteric fever, they are fevers of more than 2 or 3 weeks. In fact, if you look into the natural history of scrub typhus, it involves around 2 to 3 weeks in duration. Why this is important is that is where earlier, if you are failing to pick up or suspect a case of scrub typhus, the patients may move from one doctor to another doctor and later he may develop complications. So that is where follow-up of each patient, even our patients come to us as outpatient department for acute febrile illness, it's always that we have to follow up the patient and also make sure that relevant investigations are done at the appropriate time. So these both are important. What investigation and what duration of illness. For example, there's a lot of discussion on NS1 antigen, IgM and IgG for dengue. So like that, for this also, let us look at what investigations, and again, for typhoid also, we are going to look. Yes, now we're coming into the events what can occur in the first week. The inoculation occurs through the bite of the chigger, and it is often painless, and again, it is unnoticed. The incubation period for this particular rickettsia is around 6 to 20 days, average of 10 days. So the most characteristic thing that what we look for is a small, painless papule, initially appears at the site of infection and enlarges gradually. A central area of necrosis develops and is followed by a eschar. Normally say நம்ம ஒரு burning cigarette எடுத்து நம்ம ஸ்கின்ல வச்சு எடுத்தோம்னா என்ன ஒரு wound or ulcers form ஆகுதோ, it is something like that. But the most interesting, this very, very important clinical point, is it easily picked up in our practice? No, because this particular chigar bites at places where it is very moisty. For example, in humans, they say these chigars, they normally bite in the axilla, in the groin, in the external genitalia, or under the breast tissue like that. Why this is important is normally these sites in our busy practice, we never look, or sometimes even patient themselves may not have a look at these eschars because they are appearing at a very, very unusual sites. And again, they appear only in around 30 to 50% of patients, and we have to look for it, and again, pathognomonic scar can be picked up. Otherwise, it may be easily missed. And it is, as I said, it is like a black necrotic lesion resembling a cigarette burn, where I already mentioned moist areas and wrinkled and covered by the tight clothing areas. So this is one of the common classical picture of a scar. It is occurs as an epidermal ulcer covered by a black crust surrounded by an erythematous halo. So these are another one. Again, this is another on the side of the abdomen. Again, this is again scars. They can occur at a very, very atypical sites. Again, in our practice, we have picked up all these sites. That is why I was mentioning about proper clinical examination from head to foot on every day. Suppose he comes today and again he comes back after 2 days. Again, you start examining him as if you are examining him for the first time. So this you can see of the external genitalia, thigh, all these regions you have seen where it can appear. So again, the biopsy shows perivascular infiltrates with mostly consists of lymphocytes and macrophages. Okay, what are the other differential diagnoses that we can think when you see a scar? Could be a cutaneous anthrax or a tularemia or LGV or a Gatsfred syphilis. Okay, now, as I already said, the most pathognomonic sign is the scar, but unfortunately, it may not be there in every patient. Around 30 to 40% only it is there. So it consists of regional lymphadenopathy. Apart from the thing, it can occur at the end of first week. It is draining the regional where the scar has occurred, and it is a tenderless enlargement there. And it may result later. Apart from regional, then patient can develop generalized lymphadenopathy where it can mimic like a lymphoma also. Patients, coming to other most important feature is the abrupt onset of high fever like 104, headache, malaise, myalgia approximately after the 10th day of infection. So this is where it mimics like a dengue syndrome also. Again, when the fever appears, the scar is well formed, and fever is the most important presenting symptom of scrub typhus. And apart from that, it can develop maculopapular rashes also, which appear on the chest, abdomen, whole trunk like that. Again, it may be transient and it can be missed. So just if you look at this slide of frequency of symptoms, already I mentioned fever is the most common symptom, sudden onset of high fever, presence of scar, lymphadenopathy. Again, the other complications that can occur is the ARDS like picture. So they can develop cough, chills, rash, headache, and diarrhea. So this is a classical presentation of a acute febrile illness during the first week of illness. This is mimics like a dengue fever also. So if the patient, the clinical findings doesn't make a clinical diagnosis, or if the diagnosis is not thought or confirmed, the patient slips into a second week where he can go for complications. As I said, it is a multi-system disease. So it can involve most of our major systems. So we'll try to understand the clinical features of each system. One, central nervous system. They can develop tremors, nervousness, slurring of speech, and acute deafness. This is another very interesting clinical feature, acute deafness with short fever, think possibility of a scrub. And again, it can cause seizures and very rarely coma and unconsciousness. Next, we'll go to the characteristic problem. For example, when we talk of dengue resulting in hemorrhage shock syndrome, when we talk of scrub typhus, it mainly involves a respiratory system producing ARDS-like picture. In fact, in our Rajiv Gandhi Government General Hospital, we have treated hundreds of cases of ARDS, and many times they think of something septicemia or some other problem, but it turned out to be, many times it turned out to be a simple scrub typhus resulting in ARDS. Why I am mentioning the clinical suspicion of scrub is important, because once you give doxycycline or once you give azithromycin, this is one of the very good disease to see the clinical improvement occurring so fast. We have seen a severe ARDS admitted with ventilator and all. Once a diagnosis is made and patient is put on appropriate antibiotic, the patient recovers so fast, they can even walk out of IMCU in 2 to 3 days. So that is where clinical suspicion of ARDS due to scrub is very, very important, because it's a very good disease to treat. So when it involves, it can develop a cough, tachypnea, pulmonary infiltrates, and ARDS. And again, cardiac involvement, it can cause myocarditis, cardiac failure. Again, this relative bradycardia, again, we are going to learn in typhoid also, where, for example, normally for every 1 degree of rise of temperature, we expect the pulse rate to increase by 10, but that they don't occur in some fevers. Again, one such is scrub typhus. Again, they can go for acute kidney injury, shock, and disseminated intravascular coagulations. So all these fevers, for example, dengue or malaria or a scrub or lepto, all these things are known to cause multi-system involvement. But each disease, for example, lepto has more of renal complications are more commonly we come across. Similarly, for dengue shock syndrome, for scrub, it is ARDS. So now just to recollect the clinical features, acute onset of high fever with lymphadenopathy, they can have myalgia, they can have cough, and most important complications will be a respiratory system in the form of ARDS, or cardiac complications in the form of myocarditis or kidney injury. So it's a disease of 2 to 3 weeks. So how to confirm the diagnosis? Again, they have a leukopenia with lymphopenia with late lymphocytosis. Again, thrombocytopenia. Again, all this leukopenia, all these things can mimic like a dengue-like picture. But again, we have elevated of liver enzymes. 70 to 90% they have a transaminitis is there. Hypoalbuminemia can occur. Hyperbilirubinemia is rare. That is why when you are thinking of acute febrile illness with elevated bilirubin and elevated, think of for example, even in dengue, transaminitis is very common, but you don't see the bilirubin rising. So when you start seeing bilirubin increasing with dengue-like picture or a scrub-like picture, we have to think of other infections, especially leptospirosis or a viral hepatitis, where the bilirubin will be increasing. Again, somebody was talking about co-infection. Again, in a tropical country like ours, please remember, even in dengue, they say 30 to 40% of dengue patients are having more than one infection. That it's a very, very important clinical point. Again, Dr. Neminathan has stressed, we have seen 2-in-1 or even 3-in-1, like dengue, scrub, and malaria together, lepto, like that. So any combination we have seen. Again, the most specific test for the diagnosis of our scrub typhus is your Weil-Felix reaction. Again, Weil-Felix reaction is trying to detect the antibody titer. So if any test that going to detect the antibody titer, please do it after 7 days, because the early titer may not be significant. And again, the basic thumb rule is rise in titer. So the rise in titer, again, more than 4 times is a very, very characteristic feature of a Weil-Felix reaction. Again, apart from that, we can have other immunofluorescent assay can be done. Again, cultures, even though it's not very common, can be done. Again, IgM and other things for IgG for the acute infection and chronic infection for scrub can be done. But most commonly we do is the Weil-Felix reaction. So cultures, they are not routinely done. Again, epidemiological data to confirm, as I said, in few districts are bushy, visit to the bushy areas, all these trekking, all these things or sandy areas, they can give a clue. Again, clinical examination of eschar, regional lymphadenopathy, fever, rash, leukopenia is a very, very common clinical features and confirmed by Weil-Felix reaction. Now coming to the specific treatment. Again, as I said, it's a very good disease to treat. So before going to specific treatment, make the patient have a good bed rest, adequate fluid, make sure that hydration is ensured, and good nursing care. And as far as drugs are concerned, we are having 2 or 3 drugs, which is very, very simple, easily available, less side effect. One is the tetracycline or a doxycycline. So it can be given for a 7 days antibiotic is choice. We give 100 to 200 milligrams once daily. Only problem with doxia is it cannot be given in pregnant women and in children less than 7-8 years, where we do try azithromycin. Again, azithromycin is a macrolide which is having very promising results even for our enteric fever, which we are going to learn in the next talk. Apart from that, rifampicin has also been tried. So my simple suggestion would be in our practice is, if the patient is having fever, lymphadenopathy with eschar, straight away the diagnosis, clinical diagnosis is confirmed, and we can start with doxy or azithromycin. And maybe if you want to confirm, you can do the Wheat-Felix reaction, because the early starting of treatment definitely arrests the progression of symptoms like ARDS and other cardiac and neurological complications. And definitely we can prevent the morbidity and mortality as far as scrub is concerned. So as I already mentioned about the dose, then for other doxorubicin also been tried. As far as azithro is concerned, 500 milligrams for 3 days is enough. So 88 become afebrile and all clinical symptoms disappeared within 72 hours of treatment. So as far as prevention, as I said, rat is the regular host for this tromiculent mite to bite. So avoid all these places where they can be there. So somebody was asking for dengue vaccine. So like that, there's no effective vaccine against scrub typhus. But when you look into it, why it is not very, because for vaccine to develop, it should have a utility of major things. But here, it gives protection only to the particular strain locally. That's what the literature says. That is why a vaccine developed for one locality may not be protective in another. This complexity continues to hamper the efforts to produce a viable vaccine. So I think the points to remember: scrub is caught by a Orientia Sutsukomushi. They acquire the infection because of the bitten by the larva of tuberculous mite. The features are fever, eschar, regional lymphadenopathy, rash, and leukopenia, and they respond to macrolides and tetracycline. So this is the first part of my talk today. Any questions? Can I take it now? Sir, can I go to the next presentation? Hello? Hello? Am I audible, sir?
Sir, you are audible. You can proceed, sir.
Yeah, thank you, sir. Thank you. So we'll go to the next part of my second part of my talk, that is on enteric fever. I think this is a age-old fever which we have been treating in our country for many years, but still it's going to be a challenge for many reasons. Again, I am avoiding the word typhoid fever because now when we say typhoid, it should also include the other serovars like your paratyphoid A, B, and C. So the better term in my talk would be a enteric fever. So we'll just go by the outline of this my talk, which includes definition, sources of infection, agent, and the incubation time. Again, pathogenesis, clinical features, diagnosis, treatment, complications, and prevention. Why I say this, it's an interesting disease to manage, even though we have been managing for many years, is still it's a, all of us know it's a disease, fecal-oral route, and hygiene and water, food hygiene still has its own issues in our country. And also use of antibiotics and resistant antimicrobial resistance is another important area where it's going to be a challenge. And number 3, even though vaccines are available for typhoid, still its utility is not satisfactory. So these are the few challenges. So that is why still enteric fever is a disease to be managed in our day-to-day practice. So before I go to the presentation, let me completely define the three important terms as far as the typhoid is concerned. One, we call it as a confirmed enteric fever, probable enteric fever, and chronic carrier stage. So what we mean by confirmed enteric fever is fever of more than 38 degrees Celsius for at least 3 days with a laboratory confirmed positive culture. So when we say laboratory confirmed positive culture, usually we do blood, but as we go later, I'll also tell what are the other things that can be cultured, including bone marrow or the bowel fluid of Salmonella typhi. At this moment, I want to express my personal opinion. In our day-to-day practice, is it really possible to do a blood culture for all our acute febrile illness? Maybe in the end of my discussion, the participants can give their feedback, because it may not be possible in every situation of acute febrile illness when you're suspecting typhoid to go for a blood culture. And also use of antibiotics before patients coming to us is another problem. 1 second, sir. Up here. Okay. Okay, 1 second. இப்போ தெரியுதா? கொடுத்துட்டேன். இப்போ okay, thank you. Okay. Okay. So we are talking about three important definitions. Sorry that slides were not visible. So we are talking about confirmed enteric fever. So as I said, to get a blood culture in every patient, it's going to be a difficult task that we will take. But definition says when you say confirmed, it should be culture positive. Or it could be a probable enteric fever, where fever of more than 3 days duration with positive sero diagnosis or deduction of antigen test, but without, that is, you are doing a antibody titer in the form of Vidal test with rising titer. It can be taken as a probable. And again, another interesting disease, another interesting point that we have to understand as far as our typhoid is concerned is the carrier state. Again, the most interesting, the typhoid, Salmonella typhi bacillus, humans are the only host and reservoirs. For Salmonella typhi, humans are the only host and reservoirs. So many of the still typhoid fever outbreaks that can occur are only because of the human transmission, human to human. And also, all of us remember the typhoid Mary when we reading about the thing in New York restaurant, around 50 people were infected by a food handler in that case. So we have to be very careful, even in our private practice. As far as food handlers are concerned, they must be routinely screened for this particular carrier state. So what does the definition say? Excretion of Salmonella typhi in stools or urine in the form of repetitive positive bile or duodenal string cultures for longer than 1 year after the onset of acute enteric fever. So at this moment, I will just try to define the carrier state further also. We classify carrier state of typhoid into 3 types. One is convalescent. That is, convalescent means 3 weeks to 3 months after recovery of the typhoid fever, the person continues to excrete this bacteria in the stool. So it is called convalescent, 3 weeks to 3 months. When it continues up to 3 years, that is from 3 months to 1 year, it is called temporary carrier. Then according to this, chronic carrier means they are carry for more than 1 year, because they are the potential sources for infection and outbreaks in the, especially in hostels or in hotels like that. So whether they can be picked up, yes, they can be picked up from the culture what just now I mentioned. And we have one more tool, what we call it as V1 virulence antibody test is of value when you are screening for this carrier. So it's a blood test. The presence of V1 virulence carrier antibody can be used as a screening tool. Okay. So as I said, humans are the only natural host, and most common sources of food or water contaminated with feces. Again, are fruits and raw fruits and vegetables contaminated with sewage water. Again, another common thing is your cold items like your ice cream. So these are the common sources for the getting infected because of typhoid bacillus. As I said, the Salmonella enterica is a broad species with multiple serovars are there. One of them is Salmonella typhi. Again, we have Salmonella paratyphi A. That is the most common in the world. Again, in India also, it is most common. We have a Salmonella paratyphi B, which is more found in Europe. Again, paratyphi C, it's a rare of the three. Again, it's found in Far East countries. Again, incubation is around 5 to 15 days. This is very important. What happens once a bacteria enters the GI tract? What happens next? Again, the acid in the stomach doesn't really protect. That is why even in normal people, it can bypass the stomach and enter the ileum and small intestine. And especially in people who are having aclohydria today, that's a very important clinical point. We are using this pantoprazole, omeprazole, all these proton pump inhibitors for various reasons. So all this will suppress the acid. Again, that facilitates the infection due to typhoid. So that also we have to keep it in mind. So after ingestion, they penetrate the mucus. That is the characteristic part of the intestine that it picks up is the Peyer's patch. So they pick up the Peyer's patch of the small intestine, and it is there phagocytosed by the macrophages. Then it disseminates throughout the body. It affects most of our body through the lymphatics, and they colonize in the reticuloendothelial system of liver, spleen, lymph node, and bone marrow. So this is what happens during the incubation period. Just now we saw the incubation period is around 5 to 15 days. So after ingestion, this process occurs in our body. Again, at this moment, I'll try to differentiate because typhoid also causes ulcers in the GI tract. Our tuberculosis also causes ulcers in the GI tract. But the way it causes is different. It produces horizontal or vertical ulcer. Peyer's patch are more of vertical. So it causes the Salmonella typhi picks up Peyer's patches. So it produces oval ulcers and bleeding and perforation. Tuberculosis ulcers will call strictures, circumferential ulcers, and it will cause more of intestinal obstruction and strictures. So this is how both the TB and typhoid affects the intestines, but the mode is different. Okay, now we'll come to clinical presentations. So again, the fever is the most common symptoms. Again, in fact, typhoid fever, they say it can go up to even 4 weeks of illness. So what happens during every week, we'll try to understand it quickly. So it exhibits, I think the time-old classical description is, we call it as a step ladder pattern. So what we mean by step ladder, the temperature rises over the course of each day and drops by subsequent morning. Again, it picks up. The next slide you can see, it is like the reaches peak, comes down. Again, next day it goes up. Again, so like that, every day the peak goes up, starting from around 37, 38 to 40, 41. So this is a classical presentation of a stepladder fever of a typhoid or an enteric fever. Next common presentation is the diffuse abdominal pain and tenderness. Sometimes it's a colicky, mainly in the right upper quadrant. Again, as I mentioned about infiltration in the Peyer's patches, causing inflammation and narrowing. Again, another interesting thing is we normally say vomiting, diarrhea, especially in children, but they say in adults, constipation can also occur. Then other non-specific symptoms like dry cough, dull frontal headache, delirium. It's a very, very important. In fact, the word typhoid itself, it means delirium. So one of the common differential diagnoses in our busy practice is fever with delirium. Of course, we think of malaria, typhoid also, apart from other meningoencephalitis. But one of the common, what is delirium is clouding of consciousness. So stupor, again, I'm showing some other study which showed the common neurological manifestations of typhoid. We'll again come back in the later slides. So they can have a delirium. So acute fever with delirium, one of the first differential diagnosis is typhoid and malaria. So what happens during the second week? So above symptoms and signs, they progress. And even though we read rose spots, I think in a dark skinned people like Indians, it's very, maybe the audience can say whether they have picked up this thing. But anyway, the textbooks do mention about these rose spots. But interestingly, it's a very important point because we can take biopsy from these rose spots. I was mentioning about biopsy, cultures. So one of the things we do normal is blood culture and bone marrow culture like that. They say you can take a culture because that represents the bacterial emboli to the dermis. So what is it? It's a salmon-colored blanching maculopapules occurring in the chest and abdomen around 1 to 4 centimeters in length. So you can see all this. But to be very frank, I have not seen in my practice. So they can go for abdominal distension. Again, soft as compared to malaria, where you get a foam spleen. Again, I was mentioning about relative bradycardia. So as I said, they can have a, for example, temperature of 1 or 2, that pulse rate may be only around 80. And another interesting clinical finding is your dicrotic pulse. What is dicrotic pulse? Is double beat. The second beat is alternating with strong and weak beat. So these are the few important things that we can. One of the relative bradycardia is easily picked up in our practice. Then what happens during the third week? The fever may persist. The complications really at the end of second and beginning of third week is the complication problem. So they can develop increase in toxemia, weight loss, conjunctivitis. They can go for severe abdominal distension, pneumonitis like pictures, thready pulse. All these things can occur, and they can develop even a foul green colored diarrhea. They call it as a pea soup diarrhea. And again, psychosis, confusion, psychosis, perforation, peritonitis. Again, death may occur due to severe toxemia, myocarditis, or intestinal bleed. And then during the fourth week, improvement may occur. Abdominal distension may progress. Untreated suffer from all the complications just now I mentioned. So another important thing, asymptomatic. So many of the 10 to 20% of the people can, without developing any fever or other symptoms of enteric fever, they can continue to be an asymptomatic carrier, and they could be a sources of infection. Okay, now coming to the investigation, how to confirm our clinical suspicion. So this is a good slide telling what tests to be done during which week of the illness. So commonly what we do is a complete hemogram. So I'm going to give you some simple tips on which you can make a diagnosis without even waiting for your blood culture. We already discussed about stepladder fever, delirium, clouding of consciousness, relative bradycardia, all these things, coated tongue, hepatosplenomegaly. Yes, especially during the first week, you have hepatomegaly. During the second week, patient develops soft splenomegaly like that. So one test, complete hemogram will show, usually it shows leukopenia and eosinopenia. That is very, very characteristic feature of a typhoid. Eosinopenia is very important. Again, we are talking about blood culture. And nowadays we are talking some new upcoming card tests and other things like typhoid.m. Again, as far as Vidal, please do not do on first week because it will tell you only the baseline. Maybe the second week you can look for, or even if you do in the first week, rise in titer during the second or third week will be confirmatory for your confirming the enteric fever. So still the gold standard is your blood culture. I'll give you some few important points for taking a blood culture. They say the amount of blood to be taken for a blood culture is directly proportional to the positivity. That means they say, in fact, we have to take around 20 to 30 ml of blood, even though it's a very difficult thing, but that's what the guideline is telling. More the quantity, better the being positive. Number one, again, before the onset of starting the antibiotic, which is a very difficult thing in our practice. Most of our patients, they do take self medications. Number three is sometimes you have to repeat today morning, after 24 hours, again after 1 week. That's what they say. 3 times also they have to be repeated. And again, importance of stool culture. Again, so one advantage of stool culture is it can be positive even if the patient has taken antibiotics. Same thing for the bone marrow also. So one of the area where you can do a culture for typhoid is bone marrow. That will overcome the issues relating to your use of antibiotics. Of course, you can take the gastric aspirate from the bile also, that can be used. So these are the important investigations. Still, gold standard is culture or blood viral or your typhoid dot and typhoid.m card-based test. Again, you can look for ultrasound for hepatosplenomegaly. Again, I mentioned about the various cultures that can be useful. Okay, coming to the once diagnosis is confirmed, one of the important thing in treatment, before I mention about the antibiotics, one of the important thing in typhoid fever is taking care of hydration, because a lot of toxemias are there. Adequate fluid management is very, very important. Make sure diet. In fact, those days, those senior doctors will remember, those days we used to have an enteric ward separately. For example, in Madras Medical College, in second floor, we had a typhoid ward. Only the patients of typhoid were admitted. They were given a very soft diet and a good hygienic environment like that. So the diet is very important. Taking care of hydration is very important. Of course, the most important is appropriate antibiotics. Again, in our practice, we can manage around 80 to 90% of our patients can be managed as outpatient if the patient does not have any warning symptoms and signs, which I will discuss later. So coming to the antibiotic usage, so we can classify enteric fever into uncomplicated and complicated enteric fever. Again, in uncomplicated fever, whether they are responding to quinolones or quinolone resistance. Because all of us those days, we remember we started with chlorophenicol. For more than 100 years, we have been using that. But of late, we are even using co-trimoxazole like that. But then we switched over to quinolones. And I'm sure even today's context, ciprofloxacin resistant is also a challenge. But if it is sensitive, still quinolones are the drugs of choice. For want of time, I'm not going to the individual dosages. You can just see it on the screen. So it's a good drug. Quinolones are a good drug to start with for 10 days. And again, if you are feeling quinolones are resistance, so that is where this cephalosporins comes into picture. So one of the common drug we use is cefixime, 20 milligrams per kg body weight for 2 weeks. Again, another very interesting drug we are mentioning about azithromycin for scrub typhus. So today, again, in today's context, azithromycin is also strongly recommended, especially when you're suspecting a quinolone resistance thing. Azithromycin 10 to 20 milligrams for per kg body weight for 7 days. So these are the 2 drugs that we are commonly using. If the patient is having a complicated enteric fever with complication toxemia like that, 3rd generation cephalosporins like cefotaxime or cefotaxamine can be used. Again, the appropriate dosage is given there. And again, we have to continue parenterally for around 2 weeks in time. So grossly, we can classify quinolone resistant or quinolone sensitive. Again, the 2 group of drugs is the cephalosporins and the macrolide antibiotics. So these are the 3-4 group of drugs at present available. And based on the local experience and the sensitivity of the issues, we can use all these particular drugs. Again, the duration is around 10 to 14 days is the duration. Again, some other interesting feature is as far as carrier state is concerned, they say if you want to kick out the carrier state and treat completely the carrier state of a people who are positive for this state, the WHO protocol tells 750 milligrams of ciprofloxacin twice daily for 4 months. for 4 months. That's what the guideline is telling for the carrier state. So now we'll try to end with some red flag symptoms, because this is where early referral from our primary care to your secondary care or tertiary care is very, very critical. So that let us understand the red flag symptoms. For example, headache, vomiting, seizures, altered state of consciousness, and papilledema. Again, cardiovascular, it can cause endocarditis, myocarditis with changing murmurs. Respiratory thing, it can cause lobar pneumonia like picture. Again, musculoskeletal rigidity and swelling, pain of joints and arthritis. Gastrointestinal, it can cause hepatitis. Genitourinary system, it can cause dysuria frequency. All these things are common. So, in fact, when we teach our undergraduate students, if you want to write the complications of typhoid, you can put all itis from all the major organs. That thing. Again, it can cause even a psoas abscess, gluteal abscess in very unusual situations, and hemophagocytosis syndrome like this. So these are the various complications which once you pick up, better to admit and manage in a tertiary care hospitals. So you can see the various neurological things that can occur. As I said, the word typhoid itself is mean clouding of consciousness. You can see the delirium is the most common. It can have an encephalitis, psychiatric. We have seen cerebellar symptoms, mimics like meningitis, neuropathies are very uncommon, but reported. So restlessness, confusion, incoherent speech, disorientation, and morphology are the important common neuropsychiatric manifestations. So again, coming to one of the deadly complications of enteric fever is the perforation and bleed, GI bleed and perforation. When to suspect enteric perforation? When the fever is continuing, severe abdominal pain, and patient is having a leukocyte. As I said, the patient will have leukopenia in a classical enteric fever. The patient who had leukopenia continuing to show leukocytosis, continuing to see increase in pulse rate without bleed. Again, think of a perforation. Again, they say chest infection also can be a clue for an enteric perforation. So coming back to the last part of my slide, as far as vaccines are concerned, again, surgical management includes typhoid perforation closure, and also sometimes it can present as acute cholecystitis. So it can, in fact, the people with gallstone or they are more prone for carrier state. And again, chronic carrier state can be a risk factor for carcinoma of the gallbladder. That also they have been observed. So sometimes the surgeons have some role to play when a patient there, and we have a new vaccine also that has been introduced called as VITT conjugate vaccine. It is a 4th generation of vaccine. So it is an injectable vaccines. So it is given even from the month of 6 months of age, because here you can see it is these vaccinations. One in the oral can be given only at a later age, and this can be given from 2 years of age. But as compared to this, the new vaccine can be given even from the 6 months of age. So the old ones were under 2 years and 6 years, but this new vaccine, that is VITT conjugate vaccines, can be given from 6 months up to 45 years of age. It's a 0.5 ml intramuscular, and booster doses are given every 3 years. It's a very cost effective, but as I said, it has to be promoted, especially people coming from other countries who are visiting India. It can be or high risk group. Already I mentioned about high risk group, those with gallstones and other things. In fact, as far as enteric fever is concerned, the most common age is around 5 to 15 years. More than the adults, children are more prone for infections. Again, in India, they observed even children less than 5 years are also at high risk of developing this enteric fever. So to summarize, 90% of our patients can be managed as outpatient. Stay alert, examine, review every day, and examine from head to foot as if you are examining for the first time. Please identify the early identification of red flag symptoms. Avoid indiscriminate use of antibiotics. That is going to be a very big challenge. and we have to be very conscious of this thing. Again, be aware of the awareness of food and water hygiene, and identification and treatment of chronic carriers is going to be another important public health activity. We have to keep it in mind. And again, vaccination of susceptible host. Thank you. If there are any questions or any points, we'll take it up. Thank you, sir. Over to you, sir. Sir? Hello? Am I audible, sir? Am I audible? Hello? Okay. Okay. About chat okay. Okay. So I request the audience to put their comments or questions in the chat box. IgM, IgG for scrub. Yes, sir, it is available, but not freely available. The basic concept of IgM and IgG is IgM shows the acute infection, IgG shows a chronic infection. For carriers, I said one would be a stool culture is ideal, or as I said, we can go for the VI antibody test, blood test. If they are not willing for vaccine, they can take up for the antibodies test of the blood. VI virulence antibody. It is called as VI virulence antibody test for screening for carrier state. Treatment of paratyphus is also similar to typhoid only, sir. Only thing that the main difference between typhoid and paratyphoid is little bit less, I would say, less severe in its manifestations. Carrier state, I said, ciprofloxacin, it's a very costly treatment, very long-term treatment. We have to give antibiotic of ciprofloxacin 750 milligrams twice daily for 4 months. Again, steroids, definitely it is not advisable in OP practice, sir. There are few only relative indications in a severe cerebral edema like that. Maybe Dr. Suresh, who's going to follow, can add in his experience of using steroids in typhoid. But personally, I not used anywhere. It will definitely aggravate bleeding and perforation. Is Vidal really useful? Yes, it can be useful provided if you look for rise in titer. Suppose today the blood Vidal, again, there are two antigens, no, O and H antigen. O is the first to rise. Suppose if it is 1 in 80, becomes 1 in 160 or 1 in 320. Always any antibody titer, look for rise of titers. Rise of titers correlating with clinical picture is always better. ESR, I don't think it has any, it's a more of acute infection. Interval between two titers, maybe 5 days, 5 to 7 days. Yes, the quantity of blood is around, they say around 20 to 30 ml is needed. And preferably if the antibiotic is not started, before you start the antibiotic, please take the blood for culture. I think all these slides can be shared later. I will coordinate with this thing, and there are some good articles on this that also I'll try to share. Stool culture or the antibody blood antibodies is how to identify carriers. It can be repeated. It has to be repeated once in maybe 2 to 3 years. Why eosinopenia in typhoid? To be very frank, I don't know. Maybe Dr. Suresh can chip in during his talk. Yes, I can share the PPT slides, no problem. As I said, 1 in 160, 1 in 320 can be considered as definitely a significant item. I think let us make a clinical diagnosis first, which is very important. Again, when the patient is not settling down, when there is a more than one infection, when you are suspecting, all our investigation, sometimes the early treatment with the appropriate antibiotic based on history, good history and good clinical examination is the order of the day. And all these antibiotics, what we are mentioning, either your doxycycline or azithromycin or a sulfaxime or your third generations, I think they are freely available, and you should not sometimes wait for everything to be started. So I personally feel even use of doxycycline in controlling the cytokine storm, recently many papers are also coming up. So these drugs, what we normally practice in our primary care level, I feel it's a good drug, economically cheap also, and not that much of side effects. So we can start quickly. Seafarers who are carriers for typhoid but asymptomatic, do they need, if they handle foods, if they are handling food handlers, have to be definitely treated. Okay, I think Dr. Suresh is already joined. So I'll just sign out, sir.
Sir, am I audible?
Yeah, sir, you're audible, sir. You're audible. I think you can start. You can start your sharing. Is it possible?
Am I audible?
Yeah, you are audible, sir.
Okay, sir. Okay.
You can start.
Yes.
Yeah, your slides are visible, sir.
I hope my slides are visible and I'm audible.
Yeah, you're audible. You're audible and slides are visible.
I was speaking, I'm not able to listen fully there. I'm able to see slides. I hope it is here audible as well as my slides are visible. If not visible or not audible, please call and inform me that, or please call, because message is very difficult to see at this point of time. Yeah. So
Sir,
I'm
am
going
I
to
audible?
speak about next two topics, leptospirosis and flu. What is there? Because we are before our lunch, I know. So I'll keep momentum going on. Before the disclosures, we deal with a lot of chicken pox, bird flu, swine flu, COVID, monkeypox, and everything. But don't think we are in veterinary doctors. We are in ID doctors. We do a lot of cultures and we react to the cultures in the sensitive way. So that is what we do. So we are ID doctors. We do a lot of cultures and we respond appropriately there. So my objective today is why this talk, when to suspect chikungunya or flu, or how to manage. I'll try to summarize and what is a way forward in next 30 minutes. This is a 42-year-old 42-year-old person, farmer by occupations, is coming from Tiruvallur. Fever, headache, body pain of 5 days durations. He got leg pain, no GI disturbances, no comorbids, vaccinated for COVID, conjunctival sufficiency, completed one course of chloroquine, but there is no response. What is your diagnosis now? So what do you think this patient is now suffering? How many say the patient has got leptospirosis? Please keep put it in the chat column so that we can discuss. How many say this is typhoid? Or how many say this is dengue? Because already the discussions happened between typhoid, dengue, malaria we are not discussing today. Flu we are going to discuss today. Chikungunya, all of the above. When we always put all of the above, people always tempted to know what is going on. Or none of the above. What is your diagnosis? Since this is a talk, somebody say this is leptospirosis straight away. Because of the talk, you put leptospirosis. Or what is the clue here this patient has got leptospirosis? That's the point I'm asking you. Because the talk is leptospirosis, that's why everybody say lepto, and people say conjunctival suffusion is the reason for it. Very good response, very good. Keep answering so that it's easy for us to interact with people in a Zoom meetings. Okay. So I'll give more data now. The patient's vital test has came back. O titer is 1 in 80 is positive and HS 1 in 160 is positive. Dengue IgM is positive. Lepto IgM is negative. So what do you think? This patient has got now leptospirosis. Any second thought? I just want to check. People say cough, Fusselbein. Now brucellosis is also coming in mind. But now I given more lab data. So the Vidal is negative. Vidal is positive. Dengue is positive. IgM is positive. At the same time, lepto IgM is negative. What do you think? People who answered leptospirosis, what is your thought process now? Can you go ahead and answer? So people say, I just check in the WhatsApp. People say this is chikungunya. Okay. Dengue. But dengue IgM is positive. Okay. So people say this is dengue. Dr. Nemilathan has explained to you when to suspect dengue. So people are thinking in terms of dengue now. So a lot of active participation is give a lot of energy for us to present that. Great. So I'll show some more data. So I'm going to discuss the leptospirosis. Don't think this is a new disease. This is an old disease. So I had taken from William Hostler's book of Practice of Medicines. And in that Weil's disease chapter, I have taken over. They clearly mention that disease starts abruptly and without any prodromal symptoms, often with the chills. There are headache and pain in the back. Sometimes the patient jaundice appears early. The liver and spleen are usually enlarged. Former may become tender. The jaundice may be light, but in many cases described it has been an obstructive form. So this is what the Weil's disease was described long back in William Hostler's book there. So this is how the William Hostler described the Weil's disease. That is nowadays is called leptospirosis. So this is not a new disease. This is a old disease. But if you see, this is a global disease. Previously, it is in the tropic. Now leptospirosis moved behind the tropic also. A lot of countries start seeing leptospirosis cases nowadays. Then if you see in India, previously malaria is number one. People always want to give. When I was doing my undergraduation, post-graduations, any fever, body pain, headache, chills, we need to take smear and we need to give chloroquine empirically or prophylactically or preemptively, we can call it. But nowadays, the malaria is going down for me. And what is all emerging? Dengue has already emerged. Scurf typhus is emerging. Typhoid is seeing a lot of cases nowadays. And along with flu, COVID is last couple of years back. Now flu is rampant nowadays. And dengue is again emerging. So these are all the diseases. And lepto particularly whenever people exposed to the floods, people exposed to some of the monsoons, definitely leptospirosis you should keep in mind. So either dengue, lepto or COVID. But what happened? Even leptospirosis killed more number of patients according to this newspaper article. I do not know the validity of this paper, but this is a newspaper article, particularly in Mumbai. What kills the patients more? Lepto kill more compared to dengue, compared to H1N1. Maybe the diagnosis is missed out. I'm not sure what is the reason for why the leptospirosis is killing more people. We need to check. And second thing, definitely we know leptospirosis, if you fail to make a diagnosis, leptospirosis is going to kill. That's sure. Any infectious diseases, if you fail to make a diagnosis, either the patients improve, provided the patient's immunity is good, or 10 to 15% of the population, they're vulnerable populations we can call, either because of the immunocompromise, the patient can get death due to the particular diseases is there. Then why we are presenting today, or why we are talking today to the IM fever is emerging one. Second thing, what is interesting in the study, what happened when the patient goes to the general practitioners. When the patient goes to the general practitioners, they say the death rate is high. Why? The awareness among the general practitioners about the disease is not proved. That's what the conclusion they say. If you read the conclusions, this is a public health concerns in not only in our part, this is in other part also. The awareness among the healthcare professionals is not much. But for my country like India, the study is not conducted in India. Suppose if the study is conducted in India, maybe the results may be entirely different because we are creating awareness through the IMA CGP group. So we are creating awareness. So we got a lot of cases happening here, and people are also aware. That's why people want to know what is dengue, what is chikungunya. Everything people are aware of it there. So for this group, if you do the study, the results may be entirely different for me. So why we need to discuss the leptospirosis? Leptospirosis emerges during the monsoon. Leptospirosis kills more patients. Leptospirosis nowadays is global. Not only it is restricted to the tropical country, it is global. Then what is leptospira? Leptospira again is a bacteria. This is a thin curved bacteria, very small one, that 0.1 micrometer in diameter and 6 to 20 micrometers in diameter. It's very difficult to see under the microscope. That is why we are using dark field microscope to visibly see this bacteria. And the heads are curved. Both the ends are curved in. That is why it's called a spirochete. That it's become a spiral, or the person has got a curved structure. This is called a spirochete. And it is very small one, very difficult to see through the normal microscope. Dark field microscope may help out. Is it possible to culture this organism? Yes, this is possible to culture, but we need to take the sample without antibiotics, and we need to use a specific medium called polysorbate albumin medium. We need to use it. The availability of this medium, availability of the culture is a bit difficult. Some of the reference laboratories still having it. I'll come back and how to make a diagnosis of leptospirosis in the later part of my talk. The leptospirosis species, because when we send to the lab, they do some species ID. People got confused what to do with this ID. Usually there are two species we can put it. The genus of leptospirosis is divided into two species. One is called introgons, another is called bifluxa. Bifluxa is a common non-pathogenic organisms. So do not treat all the leptospirosis report what come to you. You need to differentiate whether it's a pathogenic one or non-pathogenic one. That is most important thing. I'll show some of the common pathogenic species of introgons like Ypres hemorrhagica, then Canicola. These are all hostilis, autumnalis, pyogenes. These are all very important pathogenic species. So we need to know which species is pathogenic, which species is saprophytic or non-pathogenic. We need to know. Unless we know these differences, people do some microscopic slide agglutination test. Some species name will come in the report. People start treating with the species. So that is not required. One. Then if you know the epidemiology, I told global distributions happen. Previously in tropical, it is more common. Now it's global distributions. Greater in the tropical area, and in the tropical area, rural background is more important for the thing. Most of the time, it is underreported because people are not suspecting, or people are using an antibiotic called doxycycline or azithromycin that is taken care of the leptospirosis, so the underreporting can happen. Usually, it is maintained in the rodent populations where it is a chronic form. It is not going to kill the rodent. It is just manifesting in the rodents and continue to manifest it, continue to excrete the pathogen. The incubation period is usually 10 days, ranges from 5 to 14 days. The primary route of transmission is usually contact with the bacteria, particularly walking in the rainwater, wading in the rainwater. So this history is very important. Don't give the history of leptospirosis. IgM is positive. Leptospirosis mat test is positive. That is not important to me. First thing, the patient should have risk factors. For example, recreational exposures. One. Second thing, exposure to the flood water. Not just walking in the rain. Walking in the rainwater where your foot is submerged in the water for quite some time. Second thing, occupational. People working in muddy areas. For example, farmers, veterinarians, abattoirs, lab staff. These are all the people vulnerable. So we need to take proper history. What is a job? What you did? And household contacts is also possible. Contaminated rainwater, walking in a barefoot, that is more important. Or you can walk in a almost knee-feet water, even though you are wearing a footwear, but you are walking in a knee depth water. Some of the cracks or some of the ulcers in the foot that can that can allow the passage of the bacteria inside your body. Rarely aerosolization is possible, or direct contact with the animal is possible. This is why veterinarians is very vulnerable to this type of diseases. So we need to know the epidemiology. It is happening everywhere in the world. One. But during the time of monsoon season is more common, particularly water exposures or muddy field exposure is more important. So always ask what job is doing, what he did in the last couple of days. That is more important for you. And what the pathophysiology? Leptospirosis enters through the cuts or abrasions in him, or mucous membranes or conjunctiva, or sometimes rarely you are inhaling it. After that, it disseminates in the body through the blood system. it can cause a systemic vasculitis and causes some tissue injury. So the animal exposures in the urine, vulnerable person working in the field or walking in the waters, get the leptospirosis, goes inside the body. Usually it causes systemic diseases in the form of fever, body pain, leg pain, conjunctival insufficiency. Later part, if you fail to recognize, it affects the liver, kidney, and lung. Later organ dysfunctions and death is possible if you fail to recognize. So this is a reason we need to respond. We need to identify the organisms a bit early. And it has got biphasic. The first phase is a leptospiremic or septicemic phase. That point of time, the symptoms of fever, headache, body pain, and periorbital maculopapular rash will be there. The later part, immune phase, that point of time only the immune system trying to clear the leptospirosis, producing organ dysfunctions. We need to keep in mind. So coming back to this history, what do you think now? So I given a history too. So the patient is a farmer. So what do you think? People say cough pain is indications of leptospirosis. For me, the history of farmer and the patient has got fever, headache, body pain. So along with conjunctival insufficiency, taken a chloroquine. But only thing what is against is taken cefixime. But how many days of cefixime is completed? That's more important for me. So Vidal, previous speaker alluded, one Vidal has got very little significance. Unless we do a paired Vidal test, it has got useless. Dengue IgM, again, my previous speaker alluded, false positive can happen. We need to think about it. That dengue IgM can remain positive for longer time. Up to 3 months, it remain positive one. And dengue IgM, lot of false positivities can happen. Usually IgM test always take with pinch of salt. That's the bottom line. Any IgM test, don't take with the immediately confirmatory test. Don't consider this is a confirmatory test. We need to think about whether the dengue IgM is really important or not, or any other IgM is really important or not, based upon your pre-test possibility. What is the pre-test possibility of the patients? That's more important. So what's your diagnosis here? Possible leptospirosis. Why you are saying possible leptospirosis? The patient has got typical symptoms of fever, headache, body pain. Is farmer by occupations because of exposure to the muddy area. He got conjunctival insufficiency and leg cough muscle tenderness is present. So this is why I think possible leptospirosis here. So this is conjunctival insufficiency. Usually we examine the patients. You can get it right now. So if you see what is the common symptoms and signs, we need to go for publications. If you see this is an Indian publication, almost 74 hot cases they got published. What is the most common symptom? Headache is most common symptom. Second, followed by myalgia. The body pain is present on 68% of the occasions. Then you can have jaundice. You can have some hemoptysis. Again, the patients might have lymphadenopathy. These are all possible and rash may also happen. So this is a basis of leptospirosis we need to keep in mind. According to the Indian data, I've shown the pictures now. And this is a beautiful infographic created by BMJ. Leptospirosis means rashes will be there. But if it is full blue, for example, focus a column, the fourth one, sorry, I didn't highlight it there. Focus this one. The patient has got rash. The patient has got lymphadenopathy, conjunctival insufficiency, or the patient has got muscular tenderness. Think of it. And thrombocytopenia is also possible. Whether this is a blue one is a mild disease, red one is a serious disease. In serious disease also, the patient might have jaundice. The patient might have respiratory distress is possible. And acute liver cell failure is possible. So this is a beautiful infographic to compare all the illnesses what we are discussing now. Then how to clinically make a diagnosis of leptospirosis. This criteria is called modified Fain's criteria. They got scoring systems. One is called Part A, based upon the clinical signs and symptoms. Part B, based upon the epidemiological exposures. Usually we divide the people into two categories also. One is clinical signs based and second thing is risk factors based. For example, the patient has got fever, conjunctival insufficiency, myalgia, meningeal irritations, jaundice, proteinuria, and along with epidemiological exposure, heavy rainfall, flooding, or animal contact, think about it. So always any infectious disease, the bottom line is what is the chances of the patient is getting the disease. For example, the previous speaker talking about a typhoid fever, when to suspect typhoid fever, a patient is an young individual eating most of the time outside food because this is a foodborne disease. So when a person is eating outside food, whichever food is not cooked, not boiled, vegetable salads, fruit salad, ice cream, juices, pani puri, chutney, curd rices outside, the chances of getting typhoid is very high on the card. So we need to know what is the epidemiological risk factor. What is the risk factor for scrub typhus? Walking in a bushy areas, went to the bushy areas, did some trekking, think about scrub typhus. So when to think dengue, sudden onset, lot of mosquito bites, we need to think about it. So this is called Fain's criteria. Clinically, you can suspect leptospirosis based upon the criteria. But if you see the sensitivity and specificity, it's not a great thing. The sensitivity and specificity is not very high. But if you combine some lab report, yes, it is possible. We can make a diagnosis of it. So what is the characteristic feature of the leptospirosis? See this part. The part is combinations of the conjunctival sufficiency, icterus, sometimes muscular pain. We need to make a diagnosis. But what is the important clinical pair? How to differentiate scrub typhus and leptospirosis? Both has got muscular pain. Leptospirosis, muscular tenderness. If you start examining, if you're palpating the muscle, the patient will winches with the pain. But for scrub typhus, the palpations relieves the pain. So this is a subtle clue we can make it able to differentiate lepto versus scrub, because lepto and scrub almost closely mimic each other. But in leptospirosis, the person can winch with the pain when you do your palpations, but scrub typhus it may relieve the pain. So coming back to this case, now you think even though the lepto IgM is negative, I told them clearly IgM serology always take in mind, because all IgM serological tests take minimum 5 days, but ideally after 7 days only it turn positive. That's the bottom line. So why the test is negative here? The patient does not form the antibody here, because minimum timeline is 5 days, but it can form after 7 days. Yes, I'll show them. I'll show the evidences why it is we need to wait. Why dengue IgM is positive? Maybe the patient has got past infections or dengue that is remains still positive, or sometimes the leptospirosis can cross react. It's called false positivity is also possible. Vidal is a useless test because particularly single Vidal. If you do a Vidal, it can remain persistent for last 3 to 6 months also. That is why we never do Vidal in our practice to make a diagnosis of typhoid. So that is useless test we usually consider. Now, is there any clue to suspect leptospirosis? Yes. What is an important test for a general practitioner? Do the complete blood count. Do LFT test. Based upon the blood count and LFT test, you can make a diagnosis of most of the tropical infections. For example, in dengue, hemoglobin is concentrated. More elevation of hemoglobin will be there. In malaria, the hemoglobin will be a bit low. Typhoid and leptospirosis, hemoglobin may be normal or below normal. Then WBC count. The WBC count is elevated. Think of leptospirosis or scrub typhus. WBC count is below normal. Either 4,000 means below normal, 2 possibility. Either dengue or typhoid is possible. So differential count, C, eosinophil count. Why the eosinophil count? People are asking. Eosinophil count, usually all intracellular organisms mount a good immune response where lymphocytes overtake and it masks the eosinophil production. But that is not classic of eosinophil. But usually we see in our experiences, eosinopenia is a marker, but eosinopenia can happen with all intracellular bacteria. Is possible there. Then second thing, platelet. Platelet may be low. In dengue, it is low. In malaria, it is low. In leptospirosis, scrub typhus, it will be low. But dengue, it is too low. Leptospirosis and scrub typhus, it varies anywhere between 60,000 to 1 lakh. It is not below 50,000 or below 25,000. That's a clue. Then if you see the LFT test, SGOT, SGPT, alkaline phosphatase. Usually in dengue and typhoid, OT and PT is more because that is hepatocellular pattern. On the other hand, leptospirosis and scrub typhus, either cholestatic. Cholestatic means alkaline phosphatase may be elevated or bilirubin, total bilirubin may be elevated. Sometimes the mixed pattern, both alkaline phosphatase and mild SGOT, SGPT is possible with lepto and scrub. So this is a differential diagnosis and eosinopenia is a marker. If you see the direct bilirubin elevated, leptospirosis or scrub, indirect bilirubin elevated, think of hemolysis due to malaria. So these simple charts can give you an answer what you are thinking about it. Then laboratory diagnosis. What laboratory diagnosis? Culture is a gold standard. Unfortunately, it lacks sensitivity. It is not available also. Cost is not major thing, but its availability is a bit challenging. Specific. Once the lepto culture is positive, it's lepto. It's not a false positive. Dark field microscopy, it is easily available, but the sensitivity is very poor. It's sensitive, but the specificity is hardly nothing. Then people do microscopic slide agglutination test. Send it to a Madhavaram lab or something they used to do, some references lab, MGR University they used to do. But this is a good test. Again, single titers, I titers has got value, but we need to wait for minimum 5 to 7 days. But what is available practically to everybody is IgM serology for leptospirosis. That is easily available. It is not that costly also. But again, the sensitivity is good, but specificity is not 100%. Lepto IgM positive means it is not lepto. Maybe something else is also possible. But what is the best way to confirm leptospirosis? Ideally, PCR. Previously, PCR was not available freely, but now freely available leptospirosis PCR. For example, the scrub PCR or typhoid PCR available, but not available freely. Leptospirosis PCR available freely. It's not very costly. We can make a diagnosis of leptospirosis on day 1, day 2. Even for dengue, also PCR available nowadays. So there is no need to wait for NS1, IgM, IgG. 5 days I need to wait. No. In the first week, when you think dengue, you can do the dengue PCR. If you think the patient has got leptospirosis, PCR is a way forward. We can able to do. Typhoid, couple of hospitals are doing in Chennai, and similarly, scrub typhus, couple of reference labs are doing for PCR. But again, PCR also say both live and dead bacilli, but most of the time it is very specific test. So do leptospirosis PCR if you think the patient has got leptospirosis. So if you see, the rapid method is going with the leptospira IgM, when the rapid test is available, but it has good sensitivity, but specificity is not great. But if you want to make a diagnosis, culture is a gold standard, or you can go with the nucleic acid amplification test in the form of PCR. PCR is available. It is not that costly also. You can able to make a diagnosis of lepto in day 2 to day 3 also. Similarly, dengue, lot of confusions happening. NS1 negative, IgM negative, day 3, day 4, I need to wait for day 5. No, you can do PCR to make a diagnosis of dengue in a week. So coming back to this patients, what treatment you're going to offer for him? Whether you want to treat with the crystalline penicillin, or patients with leptospirosis means people always want to give crystalline penicillin. So I want to check how many people want to give crystalline penicillin for a year, or ceftriaxone, or doxycycline, or azithromycin, which is your preferred choice. Just go ahead and vote so that we can have some discussions. I'll start noticing any voting for these questions. People want to know how they want to treat leptospirosis. People say doxy, very good. Doxycycline, doxy is a leader for leptospirosis as far as IMA CGP is concerned. Some people say ceftriaxone. That's a good thing there. So people are not giving weightage to crystalline penicillin. But in private practice, most of the people, once leptospirosis is positive, they ask the patients to get admitted. Because crystalline penicillin has got very short half-life, a lot of allergic reaction is possible. They want to administer CP. Nowadays, CP we are not using for leptospirosis. That's the bottom line. So why I'm not using the CP? This is a reason for it. I'll show in a minute. So on large study compared ceftriaxone versus penicillin versus doxycycline, they find there is no differences between ceftriaxone and penicillin. Similarly, crystalline penicillin versus ceftriaxone versus doxycycline is compared in one of the large trial. It showed there is no advantage of crystalline penicillin over ceftriaxone over doxycycline. Some people say severe infections, serious infections, even serious infections, severe infections. Now one good NEJM paper published recently from CMC Vellore, it shows combinations of doxy plus azithro, that's fine. Or even the combination of ceftriaxone plus doxy is fine if a patient has got serious illness. So there is no advantage of CP because we need to think in mind, Jarisch-Eczema reaction is always possible if you start using penicillin. Then is there any way of prevent it? Yes. Walking in a rainwater, wading in a rainwater, avoid swimming in unknown pools. Then particularly people working in an agricultural field or muddy areas, use shoe covers. That is more important. Particularly during the time of floods, people want to know whether I can take doxycycline. Yes, doxycycline prophylaxis might help out. For patients with ulcers, cut, crack, you are going to spend a lot of time. You are a rescue worker. You are a policeman. You need to go to stand in the rainwater for a long time. Yes, you need to take doxycycline. Depending upon the risk, what is that 24 to 48 hours you can take. That can prevent the leptospirosis for you. So these are all the prevention for you. So in summary, for leptospirosis, exposure history is more important. Risk factors like rainwater, bushy areas, agricultural fields, or swimming. Symptoms you lost usually more than 5 days. Not like your dengue or influenza that lasts for 2 to 3 days. Here the symptom can last for 5 days. Headache, body pain, retroorbital pain, conjunctival suffusion is possible. Jaundice and muscular tenderness. If you do the WBC count is elevated and platelets a bit low, more of alkaline phosphatase, more of bilirubin elevations. But when you think what is the ideal test, when you think the patient has got leptospirosis or scrub typhus, start him on doxycycline or azithromycin. If you start him on doxy or azithromycin, there is no need to worry about it because serological tests need to wait for 5 to 7 days. PCR is available, but people not aware of it. But patient not affordable also. If you have got PCR, do the PCR. If not PCR, if not serology, at least if you think the patient has got exposure history, risk factor present, typical fever, headache, myalgia, conjunctival suffusions, think of WBC elevated. If you want to start. But doxy or azithro, both are equal to me. Azithro, the fever may take a little longer to subside. My next part is flu. Flu means the people always think now, previously Tamiflu, but in India, Tamiflu is not available. This is anti-flu is only available now. So this case, 55-year-old male, female, systemic hypertension with a fever, cough of 5 days duration, no shortness of breath. On examination, crackles were present on both the sides. Investigation, WBC count is 4,500. Lymphocytes is slightly elevated. He has got a grandchild 2 years, is coughing for the last 1 week. So the grandchild start going to the school and he got cough for the last 1 week. Now the grandfather also started developing fever, cough for 5 days duration, no shortness of breath. How many want to do confirmatory test for these patients? How many say I want to start PCR or treat like a pneumonia with give some antibiotics, give some symptomatic therapy, or you want to refer? So I mean, you want to see how many people want to do this one. So almost 490 people are still on online. I do not know how many on YouTube, but just go and vote. So what do you think? People want to provide symptomatic treatment alone. People want to do H1N1 test. What is our policy? You are aware of H1N1 test right now in Tamil Nadu for people coming to the OPD settings? Because I hear in the community OPD settings is very difficult to do the test. Government does not want to do the test as an outpatient setting. So follow your policy, what government is insisting. Before that, we need to know some nomenclatures. Influenza has got influenza A, B, and C. Among the A, we got hemaggglutinations and neuraminidase inhibitor. That is called H1N1, H3N1. Right now, we are seeing more of H3N1, not H1N1. We are seeing H1N1 also. H1N1 is called pandemic strain, the 2009 strain. Other one is called H3N1, H3N2. That is more common. That belongs to influenza A group only. And similar thing is, the patient has got influenza B also we are seeing, and influenza C we are not seeing. Influenza A and influenza B, previously influenza B means mild diseases, but of late, last couple of years, influenza B also behaving like a influenza A. What is our bottom line? Whether influenza A or influenza B, we need to treat the same treatment with oseltamivir that's going to work. Then depending upon the country, depending upon the isolates, we can go on. So this is the 3 types you can remember. Type A can cause disease both not only in humans, but also in other species is also possible. Type B and type C is limited to the humans. Type B and type C previously considered as mild, but nowadays type C alone is mild. Type B is usually moderate. So vaccines is available for type A and type B. So what is the classic symptoms of influenza? Cough, fever, throat pain, myalgia, headache, rhinitis. These are all the classic symptoms of influenza. But as a tertiary care hospital, what I am seeing in my hospital, it is more of shortness of breath because patients got hospitalized. That time only they come to the hospital. We admit the patients only with the shortness of breath. We are not admitting the patients with fever, cough, and sore throat. So in the hospital setting, shortness of breath more important, and organ failure, we start seeing a lot of cases. So this is a setting where you are seeing. So when a patient comes to you, how to make a diagnosis of influenza? First thing, the person should have symptoms of upper respiratory tract, fever, cough, running nose, sore throat, nose block. Along with, the patient might develop shortness of breath, possible. But what is most important thing, he visited crowded places. He's not wearing mask. People start removing the mask nowadays. People not wearing mask, going to the crowded places, attended gathering, or sick contact, either in the family or in the working stations, office or schools. If you got the patient has got sick contact, along with fever, cough, shortness of breath, or sore throat, think about it, influenza. This is what we need to think about influenza. But the most important thing, sharp onset of fever, sick contact, they exposed to somebody in the family, or he may be the first person in the family, but he can transmit the disease. After he started developing symptoms, other family members also got it. So always ask when you think influenza, anybody in the family, anybody in the school, anybody in the office has got similar symptoms 2 to 3 days back, or any travel, any gatherings, even going to the hospital, staying in the hospital for half an hour to 1 hour, the risk is there. So we need to ask this type of history to make it. So any crowded, any gathering without mask, the chances of getting influenza is very high. What about the WBC count? Normal. Neutrophils count is also normal, more of lymphocyte. That's what I shown. The neutrophils is normal, lymphocytes slightly elevated. This is a muscular pain or body pain. Anything that causes muscular pain, LDH can go up. If you fail to make a diagnosis, particularly when the patient has got comorbid, he may suffer. So this is how the patients got admitted in the ICU with a lot of respiratory infiltrates, both the sides, similar to your pulmonary edema or LV failure. The X-ray may be normal also. It has got ARDS picture, bilateral infiltrates with blown glass opacities. Previously, GGO means people think of COVID. Now, whenever you think of COVID-like presentations, think of H1N1. Nowadays, we are not seeing COVID that much. Or lobar infiltrate like pneumonia, very rare. These are all the classic descriptions. What tests? People during the time of COVID, a lot of rapid tests they did. But for influenza, the rapid test has got sensitivity of 11%. That means out of 10 people, 1 may be positive. Even though the person has got influenza, the test won't pick it up. So don't do the rapid test and say rapid test negative, I ruled out H1N1. Rapid test is positive, it confirm it. But rapid test negative doesn't rule out H1N1. RT-PCR is a gold standard. Viral culture will take time. It's not available freely to you. So what is a D test for H1N1? PCR is a D test for you. When to do as soon as possible, but up to 5 to 7 days, the positivity rate is very high. As time goes down, the PCR can also negative. That's possible. So when to which sample, nasopharyngeal sample is fine. In ventilated patients, you can take endotracheal samples also. Particularly when a patient is ventilated, instead of taking a nasopharyngeal tube, take from endotracheal tube. If you are not able to transmit as soon as possible, it should be refrigerated but not frozen. That's most important thing. So when to test? Hospitalized patients with a severe pneumonia, please do H1N1. Elderly persons, infants presenting with suspected sepsis or fever of unknown origin, please do. Persons of any age who develops fever, respiratory symptoms after the hospital admissions. Most of the time, the hospitals are not segregating. So when the person admitted for some reasons, suddenly he started developing fever, shortness of breath, respiratory distress, please do H1N1. Outpatient setting, when a patient has got risk factors, particularly the patient is a post-transplant, according to Government of India and the state of Tamil Nadu, outpatient setting, they don't want to do the testing of influenza. I do not know, because this is not a public health reasons. This is not like a water stagnations or mosquitoes brewing or something there. This is because of the winter, the season, the virus loves it, it's circulated. If you go to the crowded places without mask, I don't think so. This is a public health issue, but still the state government as well as Indian government insisting not to do as an outpatients to check influenza. If we check only, then we know what is going on. But unfortunately, we got a lot of limitations on the government side. Oh, immunocompromised, post-transplant, I need to check. Children with fever and respiratory symptoms, because any point of time they can go into respiratory distress, please check. So if you don't want to do the individual H1N1 test, because government says we can't do it, the patient is affordable, this test is a good test. It's called PCR, multiplex PCR. If you do a throat swab and send for this test, you can able to identify whether influenza is present or not, which type of influenza, H1N1 or H3N2 and second thing, COVID is still present or not. Other respiratory viruses like rhino, RSV, we can able to figure out. So this is called respiratory viral panel test. Available, but cost is slightly high. It is not available in the government setup. It's mostly available in the private care sector. It's available freely, but not freely means the cost is there. So we can able to find out what is going on. The turnaround time is 1 hour. That is more important. The turnaround time is 1 hour. We can able to figure out which respiratory illness the patient has got it. Coming back to my case history, what will you do now? We made a diagnosis of influenza-like illness. The patient has got fever, cough, some sick contact. So we need to think the patient has got influenza-like illness. Whether you want to start oseltamivir, but the patient is now presenting on day 5 or day 6 of the illness. How many say I want to start oseltamivir? So the patient is presenting to me. Cost of the multiplex PCR people are asking 15,000 bucks, but some of the private labs do 12,000 rupees. It can able to do it now. So what treatment you're going to do for these patients? Want to start, but day 5 the waiver. Usually when we start antiviral, should be start little early, but if you give little late, the chances of failure may happen. So this is the reason people want to hesitate. So what is a natural cause? 90% of the people with influenza recover. But nowadays, what we are seeing, the cough is nagging. The cough is killing the people. Even though the viral fever subsides on day 2, day 3, the cough goes with influenza for 4 to 6 weeks. In fact, a lot of healthcare persons, they themselves are asking, my cough is not going. I tried everything. 4 to 6 weeks, sometimes 6 to 8 weeks, sometimes 3 months is going on. The last 2-3 months, people who got H1N1, they are aware of it. Illness only lasts. But most of the patients, complete recovery, I don't think so. 1 week, the complete recovery means absence of the cough. That is dragging quite some time for this time. Then what are the complications? Pulmonary means we can go with a bacterial pneumonia. Similarly, for extrapulmonary means renal failure, coagulopathy, myocarditis. Whatever we encountered during COVID, all is possible with influenza. Even before COVID, these complications we've seen in influenza. Then how will you approach, according to Government of India, patients with mild diseases or mild symptoms or patients without any comorbid conditions? They belongs to category A. No comorbid, mild symptoms, do not test, do not treat also. But I'll come back and explain what we do. Patients has got category B1 means severe symptoms. Patient has got 101, patient is coughing, patient has got sore throat pain. No need to test, but go for treatment. Immunocompromised patients also, no need to test, treat it. Patients with respiratory distress, we need to test and treat. So category A means healthy person, mild symptoms, do not test, do not treat according to Government of India. Category B means either severe symptoms or immunocompromised, do not test but treat. Category C, patient has got respiratory distress, treat as well as test as well as treat. That's the policy Government of India. But according to me, the patient comes little early, particularly the amount of cough the patient suffering nowadays with 2 to 3 months is dragging. The person comes to you little early, ideally within 48 hours time. That point of time, even the person is healthy, I can start. What is the advantage for me? The transmission risk in the family will go down. The suffering can go down. So that is the reason we need to start little early, even with the patient's presence to you little early, the healthy persons with mild symptoms, because after the fever, after the body pain, the cough is dragging this time. What is the side effects of oseltamivir? Diarrhea will be there, lot of headache. But what is the benefit? The benefit, this is a benefit. The patient, the chances of developing pneumonia is bit less. The chances of going to the ICU is bit less. That is why we need to start little early, provided the patient comes to you little early. So we need to keep in mind the advantage is that this Lancet paper clearly told you can prevent pneumonia, you can prevent death or something there. So it's very important for you. Then people want to know, I used for COVID time a lot of dexamethasone. But as far as the data, 2009, we tried a couple of cases. Before the dexamethasone for COVID data, we tried. In a small observational study, it is beneficial. But randomized control trial, it is not beneficial. So what I would do, the patient has got respiratory distress, I can apply the COVID rule here. When a patient is respiratory distress requiring oxygen, that do good amount of oxygen, yes, we can, but not high doses of dexamethasone or high doses of methylprednisolone. What we did in COVID with the 6 milligram to 8 milligram dexamethasone, that is fine. So we can give for a couple of days to see whether the patient's inflammation subsides or not. So coming back to this case, he was treated by a cardiologist. His cardiologist has got a diabetes, but unfortunately, it's a controlled diabetes. He was not wearing a mask. He was attended by a postgraduate, that's a pregnant postgraduate. Again, she is also not to wear a mask. CRRI, asthmatic. 2 nurses, one is pregnant, other taking steroids for ulcerative colitis. He has got 2 grandchildren, one is coughing now. So whom you want to protect? People are exposed to this H1N1 case. During the COVID time, people exposed to the COVID, they're worried. But now H1N1, people are exposed to the H1N1. What will you do now? Start oseltamivir for everybody. Give vaccines for everybody. Can we take flu vaccines regularly? People are asking. Yes, I'll go answer this question there. So first answer, how many people say I want to give oseltamivir for everybody? So we need to know how many people want to give oseltamivir. Give vaccine for all. Give both. Watch for symptoms and treat. So what people say is give Tamiflu for everybody. Everybody says Tamiflu, Tamiflu. So what we need to do here, okay, sorry, 1 second. Yeah. Yeah. So this is a category. What I told for the treatment, same thing you can apply for prophylaxis. The person exposed to the H1N1 is a healthy person. Here, there is no healthy person exposed. For example, the CRA is asthmatic, the PG is a pregnant lady. The nurses are, one has got steroids, other is again some comorbid. The attending cardiologist is a diabetic and he's 60 plus. So what we need to do with the person attending exposed to H1N1, a healthy person, ask him to take vaccination before the symptom starts. Suppose the attending person exposed has got some comorbid illness, what I shown, take Tamiflu as a prophylactic doses or oseltamivir as a prophylactic doses for 10 days and simultaneously take the vaccines also. The third category, if after exposed to the symptoms, you start developing disease in the form of fever, cough, or shortness of breath, start treating it. So this is what we need to do. The same rule, what we did for the patients, we need to apply for the healthcare workers. We need to know this rule. So who need to take the vaccination? I given the answer. Anybody above the age of 6 months, we need to take the vaccinations. How often? Once in a year, ideally in the month of September. Why? Even though the season is going on, but our monsoon season start in the September, take what vaccines? Quadrivalent vaccine. That is called injectable vaccine. That is inactivated. Inhaled vaccine is not available. Inhaled is a live vaccine. Pregnancy is a contraindications. People say I got egg allergy right now. There is no concern about egg allergy. We can give everybody above the age of 6 months. Once in a year, September month, we need to take. What is the side effects? Mild pain will be there. Rarely you can get the fever. So every year we need to take this vaccination. That is good. But during the time of COVID, initially hesitations, later people taken the vaccinations. But for influenza also 2009, a lot of people taken vaccinations. But after 2 to 3 years of influenza over, when they asked to take the vaccination, people are hesitant to take vaccinations. Always vaccine hesitancy, even among the doctors, it is present. That's a concern. Then what mask for H1N1? Ideally, surgical mask is fine. Even for COVID, surgical mask is fine, unless you are intubating the patients or doing a CPR. And where to keep the patient? Single room is fine. If single room is not possible, you can keep at a distance of, I got put in a 2 meters distance. That means 6 feet distance is fine. Keep the windows open. There is no, if you are doing a procedures, wear a N95 mask. So the key is always alert. Not putting the mask, taking the vaccination is the best way for preventing H1N1. That is a key point. My last case here, 30-year female, primary, 5 months menstruation, 5 months of amenorrhea. This is pregnancy she got after the IVF. Fever now 3 days, body pain, back pain in palms, ankle, knee, skin rashes over the face and limbs are patchy rashes, oral ulcers. Recently treated for dengue 3 months back. Now the WBC count is slightly elevated. You can apply all the rules what we teach now. Dengue NS1. This is a post-test for people attending today. What will you do now? Treat like dengue or Nipah. Treat like scrub typhus or typhoid. Treat like lepto or flu. Treat like in your own way. Attend high DCMEs and decide in future whenever IMA CGP is conducting what you are deciding. So I expect what will happen. So before you go for some TNMSC credit points, I expect everyone should have answer. Then only they get a TNMSC credit point for this one. This is a post test for today's CME. So 30-year female, primary, 5 months amenorrhea, precious pregnancy after IVF, fever of 3 days durations. So people start putting there before you voting it there. So you need to vote and leave the presentation so that we can get a certificate. People say treat like lepto and flu. Okay, because the session is lepto and flu. Already we discussed. Somebody say chikungunya. Somebody say 3 lepto flu. Only 4-5 responses. All 494 we wanted so that you can get your TNMSC credit points today. Treat like lepto flu. Treat like lepto flu. Could people start voting? You keep voting there, so I will discuss it. So that's better. So chikungunya start emerging now again. So people fail to recognize this is the case what I said there. That dengue PCR is not detected, chikungunya PCR is detected. So PCR for chikungunya is also available. And in Haryana, they mentioned about 321 cases, but I've started seeing almost 25 to 30 cases in last 4 to 5 days itself. Chikungunya start emerging. How to differentiate? Similar fever, joint pain, but more of pain in the palms, pain in the ankle, pain in the knee. Some rashes is also happening. It is not a diffuse rash, it's a patchy rash, some oral ulcers. Think about it. So when a patient has got joint pain, more and WBC count is more of elevated side. It's not a normal chikungunya. Dengue it is more of normal. Whatever I see in chikungunya, the WBC count is in higher limit. It's not very high, but the upper limit, 10,000, 11,000. And similarly, the neutrophil is also predominant. And mild rash is happening, not a diffuse rash, mild rash, and more of the joints of the hand and joints of the ankle. And again, the stiffness is not great. In 2007, 2008, people are crippled. But right now, people are suffering for 10 to 14 days. So keep vigil. So unless and a lot of vaccines also are discussing. This is yesterday IDSA, Infectious Disease Society of America conference in US. They're discussing about the vaccinations, but vaccination is not yet available, but PCR test is available. So PCR is available not only for chikungunya, dengue, leptospirosis, all PCR is available. So how to approach any fever in the tropic? First thing, whether the patient is stable or whether the patient is unstable. How to find out? Use Q-SOFA. Whether the patient is conscious, whether the respiratory rate is good, systolic BP is good or not, that is more important. Then whether the patient has got septic or not septic first rule. If you are able to say the patient is not septic, any organ, for example, the patient's fever, dysuria, urgency, urinary tract infections, fever, cough, shortness of breath, pneumonia, fever, seizures, altered mental status, meningitis. If you know, find out whether any localizing symptoms or signs, any particular organ we are able to figure out means don't apply the rule. Then what day the person presents to you. Stable patients without any localizing symptoms comes to you on day 2, day 3, give paracetamol and observe the patients. The patient's presence day 3 to day 5, do some basic tests, CBC, LFT. But more than 5 days, we need to investigate. If we do these things, unnecessary antibiotic, unnecessary lab tests can be avoided. That's what they did in one of the small hospitals in Chennai. They did and executed well, and they shown the benefit. For solving the problem, we need to take proper history. For example, dengue means sudden onset of fever, rash will be there. Scrub typhus, bushy area. Typhoid, eating out. Leptospirosis, walking in the rainwater. Flu, sick contact. So we need to know what history to elicit from the patients. And what tests we need to do. Malaria, don't go with symptoms alone. We need to do the test because malaria numbers has gone down. So please do the test. Typhoid, don't do the vital. Look for eosinopenia or blood culture. Scrub typhus, history, elevated WBC, liver parameters. Either do the scrub IgM after 5 to 7 days, or if you got access to the PCR, do the PCR. Otherwise, give either doxy or acitro, depending upon the pre-test possibility. Both for scrub and lepto, same thing. Influenza, sick contact, always PCR, not for antigen. Dengue, again, PCR is gold standard nowadays, is available, or you can go with NS1 antigen, only symptomatic therapy. Brucellosis, yes, cultures is ideal thing. Serology, always take pinch of salt. So sharp onset of fever, dengue, 3 to 5 days. The fever not last more than 7 days. Abdominal discomfort can present. Macular rash will be there. In typhoid, young people outside eating, bowel disturbances, either diarrhea or constipations, no response. Walking in the rainwater, wading in the rainwater, leptospirosis. Influenza, sick contact, sore throat, shortness of breath. The formula I already discussed it. So anybody want to learn more ID, please feel free to contact. Anybody wanted the clinic tele-ID support. For me, I'm dealing with a lot of seasonal fevers. I'm not able to figure out. I'm not able to remember whatever you thought. Just please feel to call us. We can provide a support to you. So this is what we can do. And the certificate course is also coming up there. So please feel free to contact me learning these ones. So thanks for the wonderful opportunity. I'll take a couple of questions, whatever you posted in the chat box. So I'll just role of antibiotic to prevent secondary bacterial infections, especially children. There is no role unless the patient has got second spike. That's called biphasic illness. The patient is initially improved, again fever, chills, and rigor. Yes, you can take it. Otherwise, there is no role for prophylactic antibiotic. It increases the resistance to you. That's why we are not doing it. Then people are asking about leptospirosis. Answering only there. Fine. Please keep people asking the questions I can answer. On all the 3 topics we can cover. Whatever things left out, I can answer. Immunological syndrome, treat like lepto, chikungunya. A lot of people responded to the questions. Very good. That's a very good sign there. So you can keep asking there so I can answer everything. Very useful messages, sir. Very nice presentation. Thanks for your comments. Please go ahead. When hostile temper in children. Usually, when the person children is a category A, the person's presence to you little early, you can give it. There's no contraindications. Only thing, the diarrhea you need to keep in mind. Apart from symptomatic treatment, any specific thing for chikungunya? No. In 2007, people used hydroxychloroquine, but during COVID time, hydroxychloroquine failed, so we are not thinking more. And strep typhus presence with low WBC count? Yes. These rules are what I have shown is 95% sensitivity, not 100% sensitivity. Sometimes we can see the strep typhus with the low count also possible. Treatment of cough, which is persisting. Yes, we know it's going for 4 to 6 weeks. People are trying with a lot of things like what do you call diethyl carbamazepine, giving a good relief, a good cough suppressants. Remote possibility, some of the worst GPs are using like a steroid, but we usually say like a steroid inhaler as a worst scenario, not as a oral steroid. You have revised everything, sir. Not everything I revised. This is approach I am doing in my practice. Need frequent classes. Yes, we are happy. If you follow us, we can provide a lot of classes to you. Can we start for a continuous cough? We still no. Yeah, nebulization is fine or inhalation is fine. That's what people are doing it there. There's no clear-cut answer for the thing because we see a lot of things. Drug for pediatric lepto. Previously, doxycycline is a bad drug for children, but nowadays we are using doxycycline even for newborn. So one time we can use. There's no teeth discoloration, nothing. But if you're really worried, you can use azithromycin. There is no big differences between doxy and azithro. Anything is fine. Please, can you tell the CBC interpretations one more time to differentiate? WBC count elevated. Think of leptospirosis and strep typhus. WBC count normal, dengue or typhoid. Differential count, lymphocyte elevated, virus. Eosinophil count absent, typhoid. SGOT, SGPT more elevated. That's called hepatocellular pattern. Think of dengue versus typhoid. Alkaline phosphatase, GGTP, cholestatic picture. Think of lepto and strep typhus. Dextromethorphan, yes, most of the things like a syrup, what is working for you, you can use it because that's what we're seeing. DEC is used for chronic cough. Yes, we can use one trial because there is no specific recommendation. This depends upon individual preferences. Practical, useful, clear presentation. Thanks for your comment. For COVID patients presenting with the fever, body pain, shortness of breath, still we can use the remdesivir. There's no contraindications for remdesivir. It's available also. Maybe given acetaminophen for fever. Yes, we can give. Can be anti-flu for children in continuous cough? No. If you start yearly, the benefit is good. But if the patient is not shortness of breath, the patient is not having systemic sign, there is no rule for anti-flu after 5th day or after 7th day. Only before 2 to 3 days, that's ideal. Is doxy 200 milligrams stand for it for severe. For routine cases, 100 milligram BD is fine. Quinolones for pediatric. Quinolone is a drug we should avoid. All drugs will work for typhoid, except ciprofloxacin, ofloxacin. You can use azithromycin. You can use cefixime, you can use amoxicillin, you can use cotrimoxazole, even you can use chloramphenicol, but not quinolone. Quinolone resistance is 90% NI. Chloroquine is gone. We need to prove all malaria by means of peripheral smear or rapid CAR test. Rapid CAR test available even in the rural part. So you can do the rapid CAR test. Don't use chloroquine for fever, not for For chikungunya is possible because the pain is persisting, but not for malaria. Budesonide nebulization. That's what I say. There is no specific guidelines for a prolonged cough following a post-viral infections. You need to design your own protocol. Cough syrup roll. Yes, people using as a placebo. It's a placebo, or you can play the mind of the patient, give some cough syrup. But some of the cough syrups containing cough suppressants, you can try that one. For example, codeine is a good cough suppressant. Unfortunately, it's not available nowadays because it's available in the combinations government is banned. Doxycycline, growth stunting, no. Usually for a newborn also we tried. Paper shows one course of doxycycline for newborn can be given. After second courses or third courses only we need to resuscitate. More of clean discolorations, not the growth. Growth is because of the ciprofloxacin in the cartilage plate. That is also now clear. We can use ciprofloxacin, ofloxacin, not for typhoid, but for other urinary tract infections, you can use it. High fever, suppository or paracetamol. That depends upon whether the child is taking orally, give oral. If the child is not taking, suppository may be tried. So can we give acetol? There is no specific guidelines. You need to use your practical experiences, what is working for you. Read what sort of cough, whether it's a dry one or productive one. Depending upon the dry one or productive one, you can use it. Dry cough is codeine, but unfortunately, codeine brands are nowadays not available because people are abusing that one. Role of Montag, we had a discussions in a group yesterday. Allergic type of cough, Montag can helpful, but other cases, Montisar is not that much helpful there. Antibiotic combinations. Usually preferred to one drug is preferred. But if you want to come down the fever little early, you can use the third generation cephalosporin plus azithromycin can cut down the durations of the fever one day. There is no major advantage except the fever can subside one day. Typhoid fever will take minimum 6 to 7 days for fever to subside. Does azithro have antiviral? No, we should not use antiviral. In COVID, clearly demonstrated azithro has got no role. Doxycycline has got no role for viral. Even for dengue, it has got no role. Pediatrician malaria, yes, same thing as adult, only thing dosage modifications. If you think the patient has got falciparum malaria, artemisinin derivative. If you think Vivox malaria, chloroquine, only thing based upon milligram per kilogram. Experience network issue, just discontinued and joined again, fine. And any elaborate much information is fine. I think we are overshooting 1 o'clock is covered. So I just leave it to the other things I can respond. I given my number, please go ahead and answer. So we can feel free when we put the answers for you there. So thanks for the opportunity. If you want to learn further, please keep this number, or if you want to get a clinical consults also possible, the tele-ID consult is possible. If you want to learn more courses on this, please feel free to contact me. Till the end of sessions, we have seen almost 460 odd people. Very good sessions. Thanks for the organizers keeping people engaged. Thank you very much.
Thank you very much, sir, for your kind, nice lecture in an elaborate manner. I congratulate all the three speakers for their wonderful session with full attendance. Thank you all for the nice presentation, everything with the differential diagnosis and everything. Thank you, sir, all.
IMA CGP team, anybody is there?
Sir?
Right, okay.
Hello? Audible, sir?
Those who want to learn more, we can contact us so that we can teach you there. Thanks for the opportunity because running late of time, so we just wind up the thing, but we try to answer. Those who want to get the answers for your specific questions, please WhatsApp the message number what we provided. All the faculty is willing to answer, no problem there. And if you want to get our slides also shared, we can provide the sharing of the slides. Thank you, IMA CGP, for organizing a wonderful CME. And people are engaged. That's more important. Till the end, people are waiting. More than 400 people are waiting in the Zoom meeting. The 500 is the maximum limit. And we got YouTube also there. I think if nobody is proposing the vote of thanks. Thank you for the opportunity. Thanks for participations. Thanks for the wonderful presentation by my previous speakers and participants.
I request Dr. Shanmugasundaram to give vote of thanks.
I'm signing off then. Thank you.
Hello, Dr. Shanmugasundaram. So on behalf of the IMA CGP, I thank all the members. I thank especially for the speakers for their sparing the time for the CGP. I thank all the participants for this wonderful session. Thank you, sir. I am audible. Hello, am I audible? Thanks. And on behalf of the IMA CGP, I thank all the members for participating in this Zoom meeting as a CME program. Thanks to the speakers and everybody. Thank you all. Thank you, sir. Sendil? Sendil? Hello. முடிச்சிருத்துங்க இது பிடிச்சிருச்சு. நான் தான் பேசிட்டேன், எல்லாத்தையும் இது பண்ணிட்டேன். அவர் சண்முக சுந்தரத்தை கூப்பிட்டா அவர் இன்னும் அன்மியூட் பண்ணாம அப்படியே வச்சிருக்காரு போல இருக்கு.